Good morning, everyone. I hope you're feeling good. The Keating team would like to extend a very warm welcome to you all on our third annual BRCA conference. My name is Helen Forrest, Director of Nursing Services at the Keating Foundation. So we've converted our seminar into a webinar to keep us all connected and honour the time we give to our BRCA space this time of year. COVID-19 remains challenging for all of us, but it has also revealed new opportunities for our infrastructure and to evolve through the use of technology and social innovation. A steep learning curve for us all, I might add, but we have mastered it to a better degree. And I hope you have the opportunity to learn more about BRCA and take away some very important messages from our special panelists today. So as a result of COVID-19, we acknowledge that some BRCA services such as testing, referrals and counselling have been curtailed, postponed or conducted in different ways. We also respect that navigating a BRCA journey in normal circumstances can be extremely stressful and difficult. So some housekeeping rules to begin with. This is slightly different, so you're all sitting at home, so you can do as you please. It is your home. But what I would suggest is that you make your screen clear and accessible for you, and that you can hear the speakers. Also make sure you're sitting comfortably. It is 2.5 hour long webinar, but do make sure you get up and move as well, because that's all part of us helping and encouraging a healthy lifestyle. Turn off your phone or silence it if this makes it all better for you. So as an attendee, you do not have the ability to speak. So you've all been invited in as attendees. You do not have the ability to speak to us or for us to see you on video. You can see us as a speaker when we speak, and you can also see our slides. We do have a Q&A session. There is a Q&A and discussion at the end of the webinar. We would love you to participate during the webinar by asking questions. You can either do this anonymously, there's a button there to press, or you can do it by name, so whichever you prefer. I would also like to mention that we have Bernie Carter, our senior oncology nurse, who will moderate the questions as they come in. So if you click on the Q&A button at the bottom of your screen, type in the question that you would like to ask and press return or enter. Now that's really important, because if you don't do that, we won't receive the question. We will receive the question and we will obviously keep a close eye on those on our side. If you like a question that's being asked, so keep an eye on the questions that are being submitted. If you like a question that's been asked and it's something that you'd like to ask yourself, you can actually press the like icon. It's like the like icon on Facebook, and that will actually upvote that particular question in the queue, so it will most definitely be answered. We will, however, endeavour to try and answer all questions as we receive them. If we don't, we will definitely answer them after the event itself. As you know, this webinar is being recorded and an on-demand video will be available to you next week by email. So I guess working on a webinar, we're connected in our own homes, obviously, and connected to our screens, but it is nice, I think, for every one of us, both panelists and audience, to actually know and give you a flavour of who's in the audience. So I'd like to welcome colleagues from MSD and AstraZeneca, our committed sponsors to our annual seminars, our Marie Keating Foundation nurses and staff, our peer-to-peer volunteer supporters, Ovacare, a group who support ovarian cancer patients, and a reminder that World Ovarian Cancer Day is on the 8th of May. So you will see prominent buildings all over Ireland lit up in teal on this particular day, promoting awareness and, I suppose, starting a conversation. Really important, particularly in our BRCA community. We have Pat Fahey, who works tirelessly with Lynch Syndrome Ireland. And again, Lynch syndrome is very well known as a hereditary non-polyposis colorectal cancer alteration. And this kind of predisposes people to certain kinds of cancers like uterine, some kinds of skin cancers, stomach cancer. So very important again as a connection. We have Michael Clancy from FAMHIS, and I'll give you his direct link afterwards. His company are launching an app in Ireland, probably in the summertime, or it may be delayed some. And this is really for families to record their own genetic history, both with clinicians and for themselves and their own family circle. I'd also like to acknowledge our healthcare professionals. Total respect goes out to them, and a thank you to those who committed to attending this morning but found themselves deployed. This would include public health consultants from the National Cancer Control Programme that we work very closely with, and they are currently redeployed, obviously, to the COVID pandemic. And more importantly, I suppose, to you, women and men who have been affected by a BRCA alteration, and understand what it is like for you and your families to live through this. You will have received an agenda from Jen in the office, and thank you, Jen, for sending that out. You can see that the program starts now and runs right through till 12:30. We do have a little coffee break in between, so just to make sure that it feels real, you can go off and get yourselves a coffee. So now I would like to introduce and are delighted really to have our panelist of expert speakers. We have this morning a diverse team of healthcare experts, and Abby, who has lived the experience, hosted by ourselves here at the Keating Foundation. And our aim is very simply to support women and men who have tested positive to a BRCA alteration. So I'd like to welcome Dr. Reem Salman, Dr. Terri McVeigh, Professor Killian Walsh, Dr. Deirdre Forde, Abaigeal Jackson, Claire Giffney, and Eoin Hanney. Now you haven't mentioned Eoin and Claire, I will introduce again at the end. Claire and Eoin are both genetic counsellors. Claire works in the public sector and Eoin works in the private sector. So if you feel that you have any questions throughout the webinar to direct to either Claire or Eoin, please submit them. So without further ado, we will start our programme. And our first speaker is Dr. Reem Salman, who is a breast surgeon, and I'd like to welcome Reem. So Reem graduated from the University College Dublin in 1996. She had a further qualification of the European Board of Surgical Oncology in 2009 and trained in breast oncoplastic surgery. And she had numerous units throughout Ireland, the UK and Italy. She's a full member of the European Society of Surgical Oncology and Irish Breast Surgeons. Reem was appointed as a consultant at the Mater University Hospital and Breast Check in 2009 to 12. She also works at Southern Trust NHS Northern Ireland since 2017, and many times talking to Reem, we talk while she's on the M1 coming back or going up. She is a clinical lecturer in the Royal College of Surgeons and has a practice in the Beacon Breast Centre, the Mater Private, and her special interest, and one of the main reasons she's here today and fully supporting us, is that she has a special interest in breast reconstruction, breast genetics and cancer risk. So welcome, Reem.
Good morning, everyone, and thank you for Marie Keating for having another day of BRCA. Today I'm going to be talking about the BRCA in Ireland and where we're going to be, where we are. No doubt breast cancer is on the increase. It affects about 1.7 million people worldwide of different age and ethnicity. It's about 1% diagnosed every 3 minutes. It is the commonest cause of death in women and overtaken heart disease. Yet we have not to forget it's becoming a curable disease through early detection, successful treatment, and certainly continuing research. We have about over 3,000 women diagnosed in Ireland every year. And we are also have not to forget there is 170,000 women live with the disease every year. Developing breast cancer is multifactorial. yet 5 to 10% are hereditary type and caused by gene mutation. One of these gene mutation is BRCA1 and BRCA2, yet there are other genes we have heard about them, and that's why we call it a hereditary breast cancer. These genes might be TP53, P10, CHEK2, and all other genes that if you went to genetic counseling, you might have heard of them. BRCA gene is a DNA repair faulty gene, occur with a mutation in chromosome 13 and 17, which had this cause uncontrolled growth of normal breast cancer cells, and that will develop into cancer. We have the next slide. About 15% of the hereditary genes are BRCA genes and mainly usually affect and present in young women in premenopausal age. We see from the curves below that every woman will be at risk of increasing breast cancer by aging. This is mainly present in the postmenopausal age. However, with the BRCA, this is at a younger age. They have a higher risk of breast and ovarian cancer, and so is some other cancer. We can see there is a slight difference between their risk of BRCA1 and BRCA2, but certainly quite significantly higher than the overall population. Next slide. Breast cancer is on the increase. What we want to know in this BRCA group is identify this group of patients at early stage, because we can do something in reducing their risk that is quite high. We want them to be genetically testing and identified, because once we identify them, we can be proactive. Genetic testing is expensive, and it needs to be cost-effective by identifying the correct cohort group. Thus, the criteria for genetic testing and eligibility require special knowledge, interpretation skills, and that comes through genetic counseling. We see here that in Ireland, we have 2 genetic centers, one in Crumlin, supervised by Professor Green, another one in Trinity St. James's unit, and this is supervised by Professor Gallagher. Certain clues in the family history might give us an idea about what's the risk of a genetic mutation in that patient or that family. This might be identified by having a breast cancer at early stage. It might be the triple negative breast cancer. Also, a high condensed of number of patients in the same family. You might have the risk of ovarian cancer at younger age, premenopausal or around the menopause in the family. A male breast cancer in the family will alarm us to look for a genetic mutation. Also, a woman developed a bilateral breast cancer. This will be another risk factor to look at any hereditary issue. Not to say childhood tumor or sarcoma or a glioma, which is a brain tumor. It might be raising the question about genetic testing. We need to keep in mind, once we identified a mutation, that does not mean we don't know about another variant that might be present. You might have heard that you have a variant of insignificance, i.e. a mutation in the gene that we do not know much about them. They might not be pathogenic now, but once we get to know more about it in the future by testing those cohort of patients at high risk, where these mutation might become pathogenic. The next slide. We need to know that these genes is abnormality, but these are some of the factors that we know, and we might not be able to do something about them. But there are other risk factors that we might be able to change and influence, such as you can see from this slide: physical activity, diet, weight, alcohol intake, hormone with HRT, Radiation, previous history of radiation to the chest due to lymphoma or any other cause might increase your risk of breast cancer. These are things we can do something, and we know those people are at a higher risk. But there are other things that we can't do anything about them. We can't become younger when we are aging. We can't change our family when we are born to them. We can't change the density of our breast, and for that reason, it is important to be breast aware all the time. There are other things that might be heard about, such as a breast implant cause breast cancer. We are learning today is not breast implant cause breast cancer. Your risk of a breast cancer is there. We have identified in a very small minority of people who have a breast implant, there is a breast implant associated lymphoma. And this is a cancer that happened around the capsule of the breast implant. We have to be breast aware, and if you have a breast implant, you have to be aware how to examine yourself and continue to identify what's your normal. So when you change to something abnormal, it's important to flag it up. Also, it's important to recognize that where we are now with the BRCA, it is the next slide. It is basically what we have worked on over many years. People might think we are not there. Yes, we are not there, but we have came a long way where we are now in Ireland. That is all with the thanks to the cancer support groups and agencies that support the vocalist and the campaigner, such as Roisin Prizeman and other women with the BRCA, to reach where we are now of service. We have 8 cancer centers. I'm presenting in the next 2 slides a data that I got from Aislinn Hegarty, a PhD student in Beaumont Hospital. Aislinn, after the BRCA Day of Marie Keating last year, she ran a questionnaire in May 2019, and we were hoping to run the same questionnaire to looking at the family history progress over a year. And that questionnaire, unfortunately, is not happened due to COVID-19 this month, but we will continue with that project in the future. There is 5 specialist-led family history clinics in Ireland. We have 2 national screening units, as I explained earlier. The NCCP now has a working group looking at family history service in Ireland, in keeping with the National Cancer Strategy, as well as trying to identify a national guidelines. Waiting time for testing had changed, so things had moved. We are now getting to be seen or even tested with result within 3 to 6 months, which has improved significantly, as we all remember, when we are waiting over a year to be seen, and not to mind you, over a year to be tested after being seen. So due to financial and logistics strains, genetic testing is offered based on strict screening criteria. That is important, and we will stick to it. We cannot screen everybody with a breast cancer for the BRCA gene. Next slide. This is just a small table which is summarize what Aislinn has found in her questionnaire in May 2019. I can show you that every center has answered, and we have a data from them. We don't have a data from the Mater Hospital because there was nobody to answer the questionnaire, and due to resources, there was no family history clinic running that month. It is self-explanatory that wide variety of scoring system is used, There is a local guidelines and not a unified guidelines. Some people might use a NICE guidelines, some might use a Manchester score, some might have adapted the guidelines to what's resources available. And that makes us think that two sisters in the same country at different corner of the island might be screened differently. So we certainly need to improve, and unfortunately we couldn't show you how much we improved over a year because the second part of the survey did not happen. The next slide. I can talk about the BEAUMONT experience. That's because I run the BEAUMONT Family History Clinic with the breast unit there. This is an established, purpose-built, specific family history high-risk screening clinic. It started in 2015 and basically runs, while it used to be runs twice monthly due to the large number of patients attending, we are now running weekly. It is a multidisciplinary team approach and certainly consultant-led service. In 2016, we've seen a 270 patients. We've seen over 400 patients last year. 47% of these patients attended, they are in the medium risk group. We see all comers, and what happens as well, we try to educate them as well as classify them. If you are a low risk, based on a combination of criteria and mainly NICE guidelines, you are discharged back to the GP. Medium risk, basically examined and put on a screening mammogram and should be initiated through the GP. The high risk group are seen annually and screened through the BEAUMONT service. BRCA carrier will have an annual review and a clinical examination and a breast imaging protocol that restrict to it. So in BEAUMONT, our BRCA community include 196 BRCA mutation patient. 93 of them had breast cancer, and 73 of them diagnosed with the BRCA at the time of their diagnosis of breast cancer. They are the first cases identified in the family. We have done prophylactic surgery on 60% of the patient. That's because high-risk patients who are BRCA positive are all offered a risk-reducing surgery. 80% of them had a reconstruction through the plastic service at BEAUMONT Hospital. Next slide. That leaves us where we are now, but where we want to be. My dream is we will have a one standard for all. This is what we want as a cancer group, as basically a BRCA group. We are to look which advisable, and that's I see it from the NHS service that a national high-risk screening program is required. Reconstruction service should be available in every family history clinic. Genetic psychology plays a big role in the BRCA service, and it needs to be available in every BRCA clinic in the country. We need to look at one-stop BRCA clinic. That is where we want to provide a full package from a high-risk screening to surgery, reconstruction option, gynecology service for ovarian risk and education, surgical oncology, menopause clinic, holistic need filled, and a psychological support. With us all working together, we will achieve that goal. But we need to remember, not everything comes at one time. This is a work in progress. Not even COVID-19 will stop us. So in 2020, it's a new era. COVID crisis taken the world in unprecedented storm of events, deeply affect the way we live, the way we work, the way we interact with each other, and everything becomes relatives. The next slide. These times, each one of us and you is asking, what's going to happen with my appointment? I have my surgery canceled. Where is my testing going to be done? How to deal with my implant? Who's going to screen me? Where do I go? And then, when is my new appointment? Is this going to be on hold? I just want to tell you all that, judging with today's view, the situation will and must come to an end at some stage. Some things may take longer than others to go back to the way before. Other may stay changed forever, but there will be a new normal. Next slide. Today, in the middle of the storm, we need to stay safe. We need to remember that we can do ourselves a justice by trying to take some control. In an era, we can't have our test for some reason, but that is temporary. We need to remember eating, being healthy, considering a good, healthy diet. It's important. Being physically active and doing a minimum of 30 minutes of physical activity a day is required. Being a healthy weight is ideal. But that's because we have evidence that a healthy diet and exercise routine decrease the breast cancer risk by 40%. On top of all this, we need to be breast aware. So what does it mean, breast aware? Examine yourself. Try to know what's your normal. You will figure out what's your abnormal. Just remember, if you have an abnormality, there is a GP, there is a breast clinic. You should go and get seen and examined. This situation is only temporary. We will go back and we will improve. The next slide. You all must know, and first I have to say every cancer unit had a leaflet, education. Any family history clinic would have educate you how to examine yourself, what you need to look for. These are all the symptoms. Anything that you feel is different from your normal, it needs to be checked in this cohort group. So my next slide is, ship don't sink because of the water around them. Ship sinks because the water that gets into them. So let's what's happening around us do not get us down. The storm will pass. Thank you. And I'm happy to answer any of your questions on the question answer session.
Thank you very much, Reem. That was very informative. And as we said earlier, we will actually have questions answered and a discussion at the end. Thank you so much. So now I'd like to invite Dr. Terri McVeigh to the screen. Not to the screen, but to the screen. Hi, Terri, how are you? Terri is going to talk to us about personalised medicine for men and women with inherited BRCA alterations. Now, I'm going to stop my show here, and I'm going to let Terri share her slides. And in the meantime, I'll tell you a little bit about Terri while she's doing that. So, Terri is a consultant clinical geneticist at the Royal Marsden NHS Foundation Trust. She undertook medical training, postgraduate, core surgical training, and a higher specialist training in clinical genetics in Ireland. She also has a clinical research fellowship in the Royal Marsden NHS Foundation and subsequently took up a consultant's post there in 2018. She was awarded a PhD from the National University of Ireland, Galway, for her work investigating the translational applications of genomic profiling for risk estimation, prognostication and treatment of breast cancer. Terri has written a lot of papers, 40 papers in total, and you will see them on screen. And there's a connection to her research gates there. Terri also holds a certificate in medical genetics and postgraduate diploma in medical science. Terri keenly supports patient engagement and education. She developed and curates a patient information website, and the website there is www.cancergenetics.ie, and that will also be available on screen on video. Thank you, Terri.
Great, thanks a million, Helen. And I'd just like to congratulate everybody at Marie Keating for organising this. It's not the easiest of circumstances, but I think it's really important that everybody has access to seminars like this. So congratulations to you all for organising it, and hopefully technology doesn't let us down. So hopefully you can all see my slides there. So what I'm going to speak today is, I've called it personalised medicine, but actually what I mean is personalised care. Because I think when people think of personalised medicine, we tend to think of treatment of cancer. And of course, what we aim to do really with carriers of BRCA gene alterations is prevent cancer ever developing. And that requires a bit of personalised care as well. So Reem has kindly covered a lot of this already for me, but I'm just going to briefly talk about what the BRCA genes are, what the risks are that are associated with inherited alterations in these genes, how they're inherited, and what you can do to manage your risk of cancer. And of course then how your treatment might change if you were to develop a cancer. This slide is just an example of your genomic information, which is incredibly complicated. We're very, very complex animals. I'm a very simple person myself, so I like to keep it really easy. If you think about your genomic information, think of it just like a big instruction manual. And when you look at your genomic sequence, it's like a big series of letters. So it's like a big long word essentially. And genes then are chunks of that genetic information. And when we talk about genetic alterations, which are sometimes called mutations, but that's a word I hate personally because it's sort of verging on X-Men territory. But what we're looking at basically are these letters to see if any are swapped inappropriately or deleted out or things like that, because that interferes with the way that that gene is supposed to work. Okay, so BRCA1 and BRCA2, as Reem said earlier on, BRCA1 and BRCA2 are tumour suppressor genes, and they do what it says on the tin. Basically, they stop tumours developing. And the way they do that is by correcting damage to our cellular DNA. And if you inherit an alteration or a spelling mistake, as I said earlier, in one of these genes, that interferes with that process, and you're much more likely to develop cancer than someone that doesn't have an alteration in one of those genes. The type of cancers that develop in men and in women with BRCA gene alterations are outlined here. So I think we're all very cognizant of the fact that, you know, because of the name, obviously BRCA stands for breast cancer. We're very well aware that it increases the risk of breast cancer, and that applies to women and to men. And I think that's often forgotten about. So men can develop breast cancer as well. It also increases the risk of ovarian cancer, and in men, it increases the risk of prostate cancer. Less commonly, BRCA carriers can also develop other cancers, including things like pancreatic cancer and melanoma. That sounds very scary, but luckily the overall risk of those is actually quite small. So the ones that we mainly worry about for women are breast and ovarian cancer, and for men, male breast and prostate cancer. Now, when we're estimating cancer risk, you'll hear us quote loads of kind of broad estimates. And the reason for that is that it's actually very hard to get an individualized risk, because the risk depends on a whole heap of different factors. It depends on the gene, so whether it's BRCA1 or BRCA2. It obviously depends on whether you're a man or whether you're a woman and what your associated organs are. It also depends on your age. And the other factors that can influence your overall risk are things like your family history and lifestyle and environment, like Reem touched on earlier on. If we think about BRCA1 for a second, the risk to a woman with a BRCA gene alteration, the risk of breast cancer, as I said, we have to give a range. So it's anywhere between 60 and 90%. And when you think of the average woman on the street having a risk of about 13%, obviously that's, you know, at least fivefold the population risk. The risk of ovarian cancer is between 40 and 60%. As I said earlier, the risk of pancreatic cancer, although it's increased, the good news is that it's still very small overall, and it's estimated to be less than 5%. The risk of melanoma is very difficult to quantify, because that again depends on your skin type, and obviously in Ireland we're all, you know, tend to be kind of Celtic skin type, so quite fair. So we're all at risk of skin cancer anyway by virtue of that. Now, luckily, we don't have a huge amount of sunshine, so that protects us a little bit. For men with BRCA1 alterations, the risks are actually pretty low. So men with a BRCA1 alteration do have an increased risk of male breast cancer, but that risk is still less than 1%. The risk of prostate cancer is actually about equivalent to the population risk, but what we know is that men with BRCA1 alterations may get prostate cancer at an earlier age, and they may have a prostate cancer that's more aggressive, and Killian will talk more about that later on. Again, pancreatic cancer and melanoma, yes, the risk is increased, but overall quite low. The risks for BRCA2 carriers then are a little bit different, but overlapping. So for women, the risks are very similar for breast cancer, about 45 to 85%, and the risk of ovarian cancer, lower than BRCA1, but certainly massively increased compared to the background population. So the risk in a BRCA2 carrier is between about 10 and 30%. Risk of pancreatic cancer is slightly higher in BRCA2 compared to BRCA1, but it's still about the 5% level. For men with BRCA2, the risks are very significantly increased. So a man with BRCA2 alteration has a significant risk of male breast cancer, between about 8 and 10%, and the prostate cancer risk is substantial. So it's between about 25 and 30%. And again, the risk really starts from quite an early age, about the age of 40. So for men, BRCA2 carries a very significant risk. Cancer risk is significantly influenced by age, however, and this is why our kind of risk interventions start when they do. You can see here, this is a diagram of somebody who has a first-degree relative with ovarian cancer. So we're looking at the risk for the daughter of the affected woman. And you can see the risk of that woman's ovarian cancer definitely influenced by her gene and whether a gene alteration has been identified in the family. But you'll notice there that the risk really doesn't start until about the age of 30. Okay, and after that then it obviously increases very substantially. You'll notice that women with BRCA2 alterations, the risk of ovarian cancer starts a little bit later, so the risk really doesn't start until about the age of 40, compared to BRCA1, where it starts at around 30 and definitely from 35 onwards. Okay. People often ask about the risk in childhood. The good news about these things is that actually the cancer risk doesn't seem to be increased in the childhood or teenage years. And for that reason, we really don't encourage genetic testing of children, because obviously the implications for them are going to be their risk in adulthood. So we prefer to leave the decision to the person that's potentially at risk. So we say, if you have children, absolutely discuss it with them, let them know. We're very happy to talk to them about it, but we really don't encourage genetic testing until they're able to make informed decisions themselves. And usually that's in adulthood, and actually more often than not it's later in adulthood. What usually prompts people to have testing is they're either approaching the age at which they would start screening, or they're thinking about having their own children. So that tends to be sort of mid-20s or even closer to the 30s, and sometimes even later for men. Your cancer risk is also very substantially influenced by your family history. So you'll notice that the girl I put up earlier on who had the mother with ovarian cancer, if we see that her half-sister also develops ovarian cancer, that risk is modified. So your risk increases for every relative that has been affected by a particular cancer type. Not a huge amount, but you know, it is definitely increased slightly. So that might change the advice that we provide to you with respect to your own risk, with respect to the age at which you would undertake your screening, all that kind of stuff. So that's why we take such detailed family histories, and that's why we encourage people to keep us updated about changes to their family history, because obviously if 3 or 4 more people are diagnosed with a particular cancer type, it might make us modify our advice a little bit. Lifestyle and environmental factors do play a role. I sort of say to people, your genetics sort of trumps everything. So even if you were to live the healthiest lifestyle in the universe, you're still going to be at increased risk of cancer, and you still will need to take very active risk reduction strategies. But there are certain things that you can do, and as Reem said earlier, some of those factors are within your control. So things like healthy weight, you know, moderate alcohol intake, all of that. But one question that comes up a lot is about contraceptive use, so the use of the pill. And GPs in particular are very nervous about prescribing the pill to women with BRCA alterations because of the potential increased risk in breast cancer susceptibility. The data about all of this is incredibly muddy, actually, and I think the reason for that is that it's very difficult to try and standardize the data that you're collecting about the pill. So obviously there's a million different types, there's loads of different doses, people stop and start it when they're having pregnancies, when they're on, you know, when they're breastfeeding and things like that. So there's a possible increased risk with people that are on the combined oral contraceptive pill in terms of breast cancer. But if you look at the data about ovarian cancer, people that are on the pill for about 5 years actually have reduced risk of ovarian cancer. And that reduction in risk is about 50%. So it's significant. So it's sort of a risk benefit analysis, really. You know, you have to take into consideration that you might reduce your risk of ovarian cancer, but increase your risk of breast cancer slightly. So what I always say to women is, look at the holistic picture. You know, if you're using the pill for contraceptive purposes only, then you might want to consider maybe, instead of using the combined oral contraceptive pill, considering the progesterone only pill, which has a slightly lower risk of breast cancer, but also a slightly lower reduction in the risk of ovarian cancer. Or you might consider taking the combined oral contraceptive pill for the 5 years so that you get the advantage of the reduction in ovarian cancer, but then stop and switch to something safer for the breast cancer risk. But you kind of have to step back and look at it holistically, because obviously the pill is used for other reasons. So things like polycystic ovaries, for acne, all that kind of stuff. So all of that needs to be taken into consideration. So it's not a blanket no, but certainly women need to be aware of the risk so that they can make their own decisions about taking it. So again, risk-benefit analysis, basically. Now, implications for the family. So obviously, if you're diagnosed with a BRCA alteration, usually the reason that you've had a BRCA test is because you've had cancer. And knowing if you've got a BRCA alteration that has caused your cancer has really serious implications, because it might change the way your cancer is treated. And that applies to things like your surgical approach. So if you've been diagnosed with breast cancer and you find out you've got a BRCA alteration, your surgeon might recommend that you have a bilateral mastectomy instead of just a lumpectomy. It changes your chemotherapy recommendations, because we know that BRCA gene alteration carriers respond really nicely to certain types of chemotherapy, particularly platinum-based chemotherapy. It might change your radiotherapy recommendations, so that, you know, they might say you're better off having more extensive surgery and avoiding radiotherapy. And obviously it opens up lots of pathways for targeted treatments, most particularly PARP inhibitors, which we'll talk a bit about later on. The other thing to deal with is, obviously you're dealing with the cancer you've already had, but then you're being told you've got a risk of new cancers and second cancers down the line. So that can be very daunting as well. Depending on your age as well, it might have implications for your family planning decisions and things like that as well. So it's certainly very, very challenging. There's also the risk to the wider family. So people often think first about their children, actually, and we've talked about that earlier on, but also about their siblings and their parents. And in Ireland, obviously, our families tend to be huge, so that can be, you know, several dozen people actually. Your relatives obviously are at risk of inheriting the same alteration as you, because they're inherited gene alterations. So obviously that has implications for the family. They're suddenly at risk of cancer, and they might have implications for their own family planning as well. But it's very powerful information, because if you can potentially prevent a cancer developing in one of your relatives, that's a really, really impactful thing to do. So let's talk a little bit about how these BRCA gene alterations are inherited. So this is dad and mum. So dad carries a BRCA gene alteration. For each of his children, there's a 50-50 chance that they'll inherit it. And how is that? How do we come up with that figure? So we don't pluck it out of the sky. Basically, the reason it's 50-50 is because anyone that has a BRCA gene alteration, you've got one healthy copy of whatever BRCA genes involved. So let's say it's BRCA1, you've got one healthy copy and one abnormal copy. And for every child you have, it's flip of the coin, whether it's the abnormal copy or the normal copy that they get. So if we say dad gives one copy to this child, mum gives one copy of her supposedly normal BRCA genes, another copy here, and this child inherits the faulty BRCA gene. And that child then is at risk of cancer in adulthood. So it's 50-50 chance, totally random, and it's 50-50 for every child you have. And unfortunately, I've had some families where, you know, the dad with the BRCA alteration has 4 children and all of them inherit the BRCA gene, and it's just luck of the draw, you know, because it's 50-50 for each child. I've also had families where 4 out of 4 have not inherited the BRCA gene, so you don't know unless you've had testing. Let's talk a little bit about cancer prevention, and of course Reem has discussed some of this already very, very nicely. If we think about ovarian cancer in the first instance, so hopefully you'll all be very familiar with the gynae tract, but occasionally there are a little bit of confusion about what the different bits are. So just to kind of explain very briefly, your ovaries are the female reproductive organs. They sit really deep in your pelvis. They secrete different hormones to control your menstrual cycle, to control your fertility, and also to release eggs. And they release eggs into these tubes known as the fallopian tubes. And the egg then goes into the womb where it can be fertilized by sperm. Near the bottom then you've got your cervix, which is what is being examined when you have your cervical smear. So your cervical smear doesn't give any information about your ovaries. All it's looking at is your cervix, okay? And then obviously you've got your vagina. So the risk of cancer in women with BRCA alterations, we call it ovarian cancer, but actually what we mean when we say that is cancer of the ovary and of the fallopian tube, and potentially also of another organ called the peritoneum, which is basically a kind of a membrane that lines the abdomen, which has cells that are very closely linked to the ovary. So we kind of call everything under this umbrella term of ovarian cancer. People often ask about screening for ovarian cancer. So as I said, the smear test, we obviously encourage you to keep having them because they are useful for detecting abnormal cells in your cervix, but in terms of giving us any information about your ovaries, not helpful basically. Scans are very tricky. CT scans, MRI scans, all of those kind of scans, not really useful in terms of screening. And the reason for that is because your ovaries sit very deep in the pelvis. There's a load of abdominal organs on top of them, so it makes it very, very tricky to see them. They can look completely normal in early cancer. So really your ovaries only start to look abnormal on scan when the cancer has breached the capsule. And it's really difficult to tell the difference between a benign cyst and a cancer. So scans aren't always that helpful on their own. People often ask about a blood test. So there's a marker that we use called CA-125, which is very useful for tracking response to therapy in people that do have ovarian cancer. We don't tend to use it as a screening test, and the reason for that is it can be increased for lots of other reasons. So it can be increased for in people with benign gynae changes, and obviously if you've got a benign gynae change but you know you're at increased risk of ovarian cancer and you get a high CA-125 result, that can cause more anxiety and more harm than is helpful. The other issue with it is that it can be totally normal in women with ovarian cancer. So we have this kind of what we call non-secreting ovarian cancer, and what that means is we know you've got ovarian cancer, you're having chemotherapy, but your CA-125 doesn't change at all. So that can be tricky as well. There is a lot of research happening trying to optimize screening for ovarian or for people at risk of ovarian cancer. And there's a group in London that are particularly interested in using CA-125 in some way as part of this thing called the risk of ovarian cancer algorithm. So what this algorithm includes is things like your age, your menopausal status, whether you're a BRCA carrier or not, and serial measurements of your CA-125. So they measure it basically every 4 months. And if it's abnormal, you get a transvaginal ultrasound scan within 2 months. And if it's normal, you have that every year. The results of this recent study were proposed to be really positive, but actually when you look at the nitty-gritty, there's a lot of questions rather than answers. So they certainly picked up more cancers than they would have had they not screened people, but the cancers that they diagnosed were still quite late stage, so stage 3B or stage 4. And really for a screening test to be useful, you need to be picking cancers up at stage 0 or stage 1 at the most. So the results of that study basically suggested that there may be a utility to using this algorithm in combination with the transvaginal ultrasound scan, but what they haven't shown is whether that actually changes your outcome and your survival overall. So what this means at the minute is that the only proven way to minimize your risk of ovarian cancer is to have risk-reducing surgery to remove your fallopian tubes and your ovaries. The risk of cancer of the womb isn't thought to be increased in BRCA carriers, so usually your womb is left in place, which makes the operation a bit more straightforward. It can usually be done by keyhole and usually as a day case. So it's a straightforward surgical procedure. Now the physiological sides of it are a little bit more tricky. Obviously, there's pros and cons to every intervention. The big advantages of this type of surgery are that it dramatically reduces your risk of ovarian cancer. It's absolutely the most powerful intervention you can do as a BRCA carrier. Reduces the risk of ovarian cancer by about 96%. There's a tiny residual risk of cancer of the peritoneum, that lining that I talked about earlier, inside the abdomen that shares cells that are very closely linked to ovarian cells. That can't be removed because it's a horrible operation and it would cause more difficulty than benefit, really. So there's about a 4% residual risk of that. So we do tell people to still be mindful about symptomatic changes and things like that, even if they've had the risk-reducing surgery. The other advantage to this surgery is that if you're a BRCA2 carrier, it reduces your risk of breast cancer quite significantly as well if you undertake it before your menopause. Not so much in BRCA1 because the cancers that happen in BRCA1 tend not to be estrogen driven. Obviously, the negative impact of this surgery is significant as well. So obviously, if you have your ovaries taken out, that essentially renders you infertile unless you go down the assisted reproduction route. And it triggers an immediate menopause. Okay, now I know Dr. Forde is going to talk a little bit about HRT and managing the menopause later on. The difficulty in BRCA carriers when we talk about HRT is that a lot of people have already had a breast cancer by the time they realise they've got a BRCA alteration, and HRT is not recommended in people that have had an estrogen-driven cancer. If you haven't had an estrogen-driven cancer, then we do recommend HRT, and actually it's very safe in women if they haven't had a preceding breast cancer diagnosis up to the age at which they would have had their natural menopause. And actually there's studies to show that if you have an early risk-reducing ovarian surgery and take HRT, your risk of breast cancer is actually less than those women that still have their ovaries in place. A premature menopause confers lots of other health risks, which is why we do recommend HRT. Those risks include things like heart disease, cognitive issues, and osteoporosis. So certainly there's lots of extra management that we need there. So things like we'll recommend a DEXA scan in the first year after the surgery. We'll recommend that you modify your behavior for heart protection. So keeping a check on your cholesterol levels, keeping a check on your blood pressure, all that kind of thing. So there are pros and cons, but certainly this is one surgery where I'm very much in favour of it. The age at which it should be undertaken is a little bit contentious. There are certain centres that recommend that this surgery is done at 35, particularly in Canada. They're very strongly in favour of this. In Manchester here, they're very strongly in favour of surgery at 35. Our protocol here in the Marsden is that we leave it until 40. And the reason for that is that if you look at the risk increase, the risk between the ages of 35 and 40 is still very small, even if you're a BRCA1 carrier. Now, it's not zero, so certainly all of that needs to be considered, but the rationale behind leaving it until 40 is that actually you spare an awful lot of people the morbidity of that premature menopause if you defer it until 40, while the risk is still quite low. But we do, again, take into consideration things like the family history, things like the type of alteration, things like that. BRCA2 carriers can afford to wait a little bit longer. So with our BRCA2 carriers, we'll certainly, consider it from 35 if they really want to, but they can get away with leaving it until 40 or even 45 in some cases, depending on the family history and the alteration in question. As I said, HRT is definitely recommended until the age at which you'd have your natural menopause normally, as long as there's no other contraindications. So people that have had DVTs and things like that, it's not suitable for them. And obviously if you've had previous breast cancer, again, we wouldn't consider that. There's a really interesting study going on at the minute called the Protector study, which is looking at whether it's useful to do a two-stage approach, to take out your fallopian tubes first, and then go back when you're closer to your menopause to take out your ovaries. And obviously we're looking very much forward to the results of that, because that would really be a game changer if that proves to be safe. But at the minute, we're not doing that routinely. It's just on a research basis at present. Okay, to manage the breast cancer risk, hopefully this will be a little bit quicker because Reem has kindly gone through a lot of this already. Your options for managing your risk of breast cancer really come down to either having screening or surgery. There's also the option of chemo prevention. So obviously we know chemotherapy is a drug that we use to treat cancer. Chemo prevention is a drug that we use to prevent cancer. Tamoxifen is a drug that's used to treat estrogen positive breast cancers. It's also licensed to prevent estrogen driven breast cancers as well. So it's useful in BRCA2 carriers, but not so useful in BRCA1. Tamoxifen is an amazing drug in terms of treating breast cancer, really, really useful, but it's quite toxic. Actually, well, not toxic, but it's a nasty drug basically. So it can have side effects in terms of weight gain, hot flushes, but it also increases the risk of things like blood clots. It increases the risk of cancer of the womb. So you need to, again, balance the risk reduction of breast cancer compared to increasing risk of those other health consequences. So it's not a hugely popular option among our BRCA carriers. The screening that you should have, it's either MRI and or mammogram, depending on your age and breast density. Mammograms under the age of 40 aren't fantastically sensitive, so MRI is preferential under that age. We start from 30, the reason being that that's when the risk really starts to increase. The risk isn't 0 before the age of 30, but it's not 0 before the age of 30 in the general population either. It's very, very rare. But the reason, again, that we don't start until 30 is because the numbers of people that you would need to screen to pick up one cancer are astronomical, and the health service just can't cope with that. In certain families, we would potentially offer earlier screening if there's lots of people affected at very young ages. So again, this keeps coming back to the personalisation of your risk estimates and the personalisation of your management. Risk-reducing breast surgery. Now, I said earlier I'm a really strong proponent of ovarian risk-reducing surgery. I'm a bit more easygoing about the breast risk-reducing surgery because overall, the survival between women that have lifelong surveillance and women that have risk-reducing surgery is approximately equivalent, okay? Slightly different in younger ages, but overall pretty much equivalent. So I very much leave it up to the woman to decide what's the right option for her. The reason it's so complicated is obviously it's a very obvious surgery, so there's lots of implications with respect to body issues, you know, it's like social implications as well, and there's surgical considerations as well. Like a reconstruction is a big operation, you know, so that all needs to be considered. But obviously, if you have risk-reducing breast surgery, the big advantage is that you reduce your risk very significantly of ever being diagnosed and having to go through treatment for breast cancer. Reduces your risk by about 95%, probably a little bit more actually. Can't reduce the risk completely because we need to leave some breast tissue to cover the implant or the reconstructed breast. So there are going to be, you know, a tiny proportion of breast cells left that may potentially develop cancer in the future, but the risk is less than 5%, which is great. The decision about whether to have the surgery is very personal, and the age at which it's undertaken is very personal as well. A lot of people tend to leave it until after they've had their kids because you can't breastfeed after a reconstruction, but it's a very complex decision. So this isn't something that people rush into. We definitely recommend taking your time to think about it, talking to the surgeons to discuss the different type of reconstructive options and things like that. Reconstructive options range from the very simple to the very complicated. Some women opt not to have a reconstruction, so that's an option as well. You know, that's the most straightforward procedure. You can have implant-based reconstructions, you can have flap-based reconstructions. So flaps basically are tissue that's taken from one part of the body to replace and create a new breast, essentially. The choice of the reconstruction that is used depends on the size of your natural breast, your own body shape, whether or not you're in the middle of cancer treatment, if you need radiotherapy. Your surgeon obviously will give you a recommendation as to what is most appropriate for you. But you have a big say in this as well, because it's you that's going to have to live with it. So personal choice is definitely something that should be considered as well. Let's move on to men, and I know Killian is going to talk quite a bit about this later on. If we talk briefly about prostate cancer, obviously we don't really have the option of removing the prostate in a risk-reducing surgery, so we do have to sort of rely on screening, even though it's not optimal. The screening that we use is based on a blood marker called prostate-specific antigen, or PSA for short. Again, similar to the CA125 situations, it's not perfect. So we know that men that do have prostate cancer tend to have a high level of PSA in their blood, but some men that have prostate cancer don't have that high level. And PSA can be increased for a number of different reasons. So your prostate sits there at the bottom of your bladder, and because of where it sits, it can be irritated really easily. So, you know, vigorous bike rides can increase your PSA, sex, ejaculation, if you've had a prostate exam up the back passage. But also if you're an older man, your PSA level is naturally going to be higher than a younger man as well. And of course, any irritation of the prostate, so any infection or inflammation, is going to cause your PSA to be increased as well. So again, that's not brilliant if you're someone that's at high risk of prostate cancer being told your PSA is high. So we do need to use it kind of cautiously. Whether or not male BRCA carriers should have PSA-based prostate screening is a little bit contentious. So there's a study called the IMPACT study, which was run by my colleagues here in the Marsden and in the Institute for Cancer Research, looking at the usefulness of PSA-based surveillance in men with BRCA alterations. Certainly for men with BRCA2 alterations, there is very strong evidence to support the use of this. So what we use basically is PSA annually with an MRI and or a biopsy depending on the PSA level. And certainly we've picked up lots of early prostate cancers because of this approach. So we routinely offer this to all of our men over the age of 40. The benefit in BRCA1 carriers is not as obvious. We don't have strong enough evidence to recommend this routinely, so research is still ongoing to see if it bears out that it is useful, but at the minute we're not certain. So we offer PSA screening to our BRCA1 male carriers at the minute, but it's only on a research basis. The guidelines haven't been updated to reflect that yet. We do recommend that all men be aware of new symptoms, so things like poor flow, needing to urinate more frequently than normal, blood in the urine or in the semen, things like that. Male breast cancer, there's no male mammogram, unfortunately, so we just tell men to be aware of any new lumps or bumps and to attend their GP if they notice anything, any changes basically in their breasts. Pancreatic cancer, as I said earlier on, the risk is increased but not massive, so the risk is still very small. Screening is not proven for pancreatic cancer, so we don't recommend that routinely. Again, we remind people to be aware of any new symptoms, and we definitely recommend that people avoid smoking because smoking can be associated with an increased risk of this type of cancer as well. For melanoma, anybody fair should be following this advice anyway, so this is kind of good advice whether you're a BRCA carrier or not. Avoid getting sunburned, avoid sunbeds. Obviously sunlight is our main source of vitamin D, which explains why almost everybody in Ireland is vitamin D deficient. But this vitamin can actually be obtained from other sources, including fish, egg yolks, meat, and of course you can buy it in Tesco or any other supermarket basically. We recommend that you pay attention to any new changes in any moles that you have. So basically if it starts to look different at all, if it starts to increase in size, if any borders become a bit irregular, if it changes colour, sensible things that I'm sure you would do anyway. For people with cancer, there's a couple of things to consider. So as we said earlier, it might change the type of surgery that's recommended to you, might change the type of chemotherapy that's recommended to you. And an exciting area nowadays is looking at the usefulness of targeted treatments in people with BRCA gene alterations. So one exciting class of drugs that we use more and more frequently is a type of drug called PARP inhibitor. So excuse my very rudimentary drawings now, but I'm going to try to explain how PARP inhibitors work. So I said earlier on, the function of the BRCA genes are to repair cell damage, okay? But actually that pathway is only one in a whole number of different methods for correcting cell damage. Another method uses an enzyme called PARP, okay? But PARP is much less useful than the BRCA pathway basically. So essentially, if your cells get damaged, your BRCA genes come in and repair them so that your cell goes back to normal. PARP is sort of there as a secondary product, but doesn't do a huge amount for normal cells. If you lose your BRCA function because you've inherited a gene alteration, as I said earlier, that damage doesn't get corrected and your cells become cancerous. What your PARP pathway does basically is repair enough damage for the cancer cell to survive, but it doesn't correct enough for the cancer cell to go back to normal. So actually having a functional PARP pathway is not actually that helpful for somebody that has cancer. So what PARP inhibitors do is they come in, they block that secondary pathway and the cancer cells die off. So PARP inhibitors have been used really successfully in BRCA-related ovarian cancer. There's some really lovely evidence to show that it's useful in BRCA-related pancreatic cancer, BRCA-related prostate cancer, BRCA-related breast cancer. So certainly we're going to see PARP inhibitors being used more and more frequently and probably earlier in the patient pathway as well. I'm not going to talk too much about this because obviously it's hard to be comprehensive in such a short space of time. But obviously, knowing you have a BRCA gene alteration might have significant implications for your decisions about family planning. Any child of somebody with a BRCA gene alteration has a 50-50 chance of inheriting the same gene change, as we said earlier on. There are a couple of different options for people in determining their family planning. Most people, to be honest, just crack on and have children normally and let them make their own decisions about testing in adulthood. Some people do decide not to have children, which is obviously their decision as well. Some people opt to have sperm or egg donations so that they can have a child that isn't at risk of inheriting the gene change, but obviously that means they're not related to them genetically. Similarly, some people opt to adopt children so that they're not at risk of inheriting it as well. There are assisted reproductive methods to make sure you don't pass on the gene change. So some people particularly here in the UK where it's funded on the NHS. You can have testing before pregnancy. So basically the sperm and the eggs of the parents are used to create an embryo in the lab. The embryo is tested for the presence of the alteration, and only an embryo that doesn't have the alteration is used for pregnancy. So that's funded on the NHS. In Ireland, it's not funded publicly, but it is available privately. So that would be an option if somebody wanted to consider it. There is potentially the option of prenatal testing, where there's testing of an embryo during pregnancy, but obviously that's an invasive procedure and it throws up the decision then whether you would potentially terminate an affected embryo that would otherwise be healthy. So that's contentious enough, to be honest. So most people, in my experience, either crack on and have children normally, and some people do opt to have the pre-implantation genetic diagnosis. So it's, again, it all comes back to personalization, what's right for you in terms of your own family. Psychological considerations. I'm delighted to see that Abby's going to be talking later on about this, because I think this, and Reem referred to this earlier on as well, like the psychological implications of having a BRCA gene alteration are very significant. And in Ireland in particular, we don't have enough in the way of support services to help with this, which is why the peer support groups are incredibly helpful to kind of address that need. You've obviously got the implications of the cancer. You've got the implications in terms of the family risk, and that can actually be quite tricky in terms of feeding back the information to the family, may cause, you know, difficulty with family relationships and things like that. So the genetic counselling team can help to a degree in sharing the information by providing kind of standard letters and helping identify who needs to be told and things like that. But obviously it's you that still has to deal with your own family members. There's lots of cancer support groups nowadays, and obviously the Marie Keating Foundation has been really leading the way in terms of providing the access to the peer support, which is wonderful. So to summarise all that, I hope I haven't gone too far over time now, but the one thing I would say is that one size fits all is not appropriate for BRCA carriers. You're an individual, you know, and should be treated as that. So we can sort of give broad guidelines in terms of what should be offered, but they will need to be personalised to each individual circumstance and your own cancer history and the specific genetic alteration in question. Risk reduction decisions are not easy. They're really not. And what I would recommend for everybody is to get as much information as you possibly can, and speak to your genetic counsellor, speak to your consultant, speak to your surgeon, and they'll help guide you through it. But make sure that you play a proactive part in that. Cancer treatment options, look, the oncologists in Ireland are fantastic and they're very up to date with the current clinical trials and what's available, so hopefully they'll be able to help you navigate that as well. And again, family planning options will need to be taken into consideration as well. As you've noticed, I've mentioned about 1 million different people, so multidisciplinary team working is absolutely essential, and luckily in Ireland there's a network of people, and you can see from today the group of people that have offered to speak today are from a lot of different backgrounds, so there are lots of interested people in Ireland that are coming together to help kind of create an MDT with a patient-centred approach. And peer support, can't emphasise it enough, it's so important, because the lived experience is really what's helpful in this kind of context. So I think now we're going to take a quick breather.
Actually, Terri, we're not.
Oh, okay, never mind.
Move on. This is the beauty of webinar. People can go and grab their coffees, and we'll carry on. Thank you so much, Terri, for a brilliant presentation there. Please keep the questions and answers coming, because all our panelists will be available to answer questions at the end of the webinar. So thank you so much, Terri. And now I need to bring Killian in, so bear with me 1 minute while I share my screen. I'll be with you now in 1 minute. I just need to get to Killian's slides. Slideshow. Okay. Sorry, Killian, I'll be with you now in a second. Can't seem to.
No rush, no problem.
Okay, I think we're there. So, okay, so just for interest, there's over 65 people in the audience, which is fantastic. I hope you've had an opportunity to maybe go and grab a coffee and do a little bit of movement. But our coffee break obviously is our own. So I'd now like to introduce you to Killian Walsh, who's a professor and consultant urologist in Galway. And Terri mentioned Killian earlier. Killian is going to talk to us about BRCA and men. Killian graduated from UCD and underwent basic surgical training in Dublin. He moved to London in 1995. And I know Killian and I know people in London, we worked together. So he undertook further training in America at the University of California and graduated as a specialist fellow in urological reconstruction in July 2002. He also worked as a consultant in King's College from 2002 to 2007. And we're very lucky to have Killian back here in Ireland with us, working in University Galway Hospital and Bon Secours since 2007. Killian has a particular interest in urology, obviously, but in bladder dysfunction, kidney and bladder cancers, female incontinence, minimally invasive techniques, and prostate cancer. And one of the reasons Killian is here with us today is he's actually very interested in BRCA and has made a video which you can see online on our website, rekeating.ie. So Killian, over to you.
Well, thank you, Helen, for that very kind introduction. And I would echo Terri's words in congratulating everyone in the Marie Keating Foundation about getting this webinar up and running. Now, obviously, if I was able to look into the audience, which I'm not able to do today, in a talk on BRCA, you would expect that the majority of the audience would be female. And here we are talking about a male disease. However, it is interesting how many patients come along to see me, and they don't usually come as singly as a man. They often bring their wife stroke partner with them. So even if the majority of the audience is female, I think there may be some relevance in this discussion taking place. Now, Terri has already alluded to some of the issues around BRCA and prostate cancer. And she did use some words like serious and worried and emotive words. And I would actually be a little bit more conservative. When I am asked, and I'm frequently asked by some women, what I've read about BRCA and prostate cancer, I usually try and calm them down by saying we're still at the very early stages of understanding this relationship. Now, Terri has talked about the impact study, which is a very good study that took place in London. But I think what's far more important is that people understand the relationship between PSA and prostate cancer. Because if someone is concerned about prostate cancer, rather than getting themselves a BRCA1 or a BRCA2 test, they would be far better off having a PSA blood test. And on that first slide that I have there, that actually is a picture of PSA. It actually has a physiological function. It's involved in coagulation and fibrinolysis and things like that. But the great thing about PSA is that it's only found within the prostate gland. If you give me my next slide there, Helen. The one thing that we can say about PSA is that if it is elevated, i.e. you go to your GP and you have a blood test, that there must be something going on in the prostate gland. Now, all men, as they get older, their prostate gets a little bit bigger. It's a natural process. And every year from about the age of 20, a man's prostate will get a little bit bigger. Interestingly, it isn't until you get to about 50 or 60 that you start developing symptoms with it. But as your prostate enlarges, your PSA goes up a little bit. And as Terri told you, younger men can get inflammation in the prostate. They often present with some pain or discomfort, and that causes a rise in PSA also. But I suppose the thing that causes most people concern is that in prostate cancer, your PSA is also elevated. So the main issue is that just because you have an elevated PSA does not mean that you have prostate cancer. You probably have something going on in your prostate and it may be worth seeing a urologist. But And that is probably the most common reason for someone to come and see me. So if you give me the next slide there. So again, PSA, as we mentioned, as you get older, changes over time. So what has been very important over the last 10 years in Ireland is that the NCCP have put together recommendations for the different PSA levels when people are in different age ranges. Now, there has been a little bit of a debate, and interesting, there was a very interesting paper in the New England Journal of Medicine last week about whether some of these ranges are a little bit low. But here we are at this point in time, 2020, and these are the recommended ranges. So essentially, if a man above 50 has a PSA, I would usually say above 2.5, it may be worth further investigating. Between 50 and 59, we allow it go up a little bit higher to about 3.5, and 60 to 69, greater than 4.5. So if we go to the next slide. But PSA, as I mentioned earlier, is just a guide, because if you have an elevated PSA, you may have no cancer in your prostate, you may just have an enlarged prostate, you may have some inflammation in your prostate, and the only way to be 100% certain whether you have cancer in the prostate is to get some tissue. And the only way you can get tissue is to get a biopsy. So the next slide there, Ellen. So summarizing what I've tried to say there is that if you are concerned that someone in your family has a risk of prostate cancer, the best thing to do is to discuss it with either a GP or a urologist. And my advice would be to get a PSA blood test. Now, in actual fact, when you go to see a urologist, one of the things that we find very useful as to whether or not you should have a PSA done at all, and you're sometimes recommending that to people, is to perform a digital rectal examination. And the reason that's important is because when you're an experienced urologist and you do a DRE, if you feel a smooth, enlarged prostate, that might tell you that that's just a benign prostate, and you may be less inclined to jump in and offer someone a PSA, and you certainly may be less inclined to offer them a biopsy. However, if you feel a hard, nasty area, you would be very much inclined to recommend a PSA, and you would be almost certainly recommending a biopsy. So a digital rectal examination helps both the GP and the urologist determine whether you should go to the next step of having a blood test or even having a biopsy. You may have read recently that after having your blood test at PSA and after having your digital rectal examination, that we don't jump straight into doing a biopsy. And this is an evolving area, but there's a lot of evidence now suggesting that an MRI scan before a biopsy may help the person who's doing the biopsy identify the most likely region of where a prostate cancer is. Unfortunately, an MRI cannot definitively tell you whether you do or do not have cancer. And it can be difficult to explain to some patients that even though they have an MRI, that we still cannot determine definitively, and therefore sometimes we have to go on and do a biopsy. However, when you're doing the biopsy, it does allow you to identify the most relevant areas in where to take the biopsy. And that's been a little bit of a progression in the last 4 or 5 years, and increasingly over the last 2 years, men are now having an MRI before they have their biopsy. So PSA first, DRE first, PSA second, MRI third, and possibly biopsy fourth. Now, again, there's been a little bit of a change. Traditionally, we used to do what we call a transrectal ultrasound and biopsy. You can get through a large number of patients in a short period of time. It's usually done under local anesthetic, but as you can see from that slide, the probe is passed into the rectum and the needle is passed through the rectum and into the prostate. Do you have the next slide there, Helen? And unfortunately, in a number of patients, somewhere between 2 and 8%, you can actually get a very severe urinary tract infection that can pass throughout the bloodstream when you undergo truss and biopsy. So therefore, there were a number of patients being readmitted, although the risk was low, with quite severe infections following the diagnostic procedure. So now we have slightly changed the way that we do our biopsy. We increasingly now do what we call a transperineal or template biopsy. And the reason that this is advantageous is that you can see the needle, rather than going through the rectum, is now going through the skin. And therefore the risk of getting an infection from this procedure is quite diminished. The only problem with this procedure is that it's much more painful than undergoing a truss and biopsy, and therefore the vast majority of people need a general anesthetic. Now we're just in the middle of a COVID-19 situation, so that one of the big issues is going to be the turnover time around general anesthetics. And on a population-wide basis, it's going to be extremely difficult to offer everyone a general anesthetic template transperineal biopsy. We may have to revert to doing a truss and biopsy as we go forward, and just have to factor in that there is that increased risk of getting sepsis. And as long as the patient is counseled and consented about it beforehand, we can usually deal with the situation if the patient's unfortunate enough for something like that to arise. Do we have the next slide there, Helen? Now that's just again a picture of an ultrasound of a prostate and the potential areas that you could biopsy. Take the next one. So what people are now recommending is that we take the MRI and we fuse it with the ultrasound, and that helps identify the most likely area of where a cancer will arise. So transperineal template biopsy gives us greater accuracy, and when you're dealing with any cancer or any lesion, accuracy is always of benefit. We'll take the next slide. So just another slide showing that usually within the prostate cancer is heterogeneous. So you can actually have one or two different areas within the prostate that are abnormal. I think Terri has gone through BRCA1, and as she said, if you are somebody in a BRCA1 family, really the risk of prostate cancer is very, very slightly increased. And if you're anxious, and I wouldn't recommend getting it done before the age of 40, but if you're anxious and you want to get a blood test done, perhaps you could get one done at the age of 40. BRCA2, as Terri alluded to, is possibly a little bit more concerning, but still not enough to recommend that people should routinely go out and get BRCA screening just because their mother, sister has been unfortunate and have a breast cancer. I would always recommend that you would get a PSA blood test from age 40 onwards if you're concerned about it, and act on the PSA, not be overly concerned about the BRCA2 risk. Can we take the next slide? Now, if you're unfortunate enough to have a cancer detected, as we said, it'll be discussed at an MDT meeting, and we can talk about the different options. And the questions that always come up with patients: if you have a prostate cancer, can it be cured? What does the treatment involve? And what are the side effects? And like everything in cancer, it depends on the grade, i.e. how aggressive it is, and the stage, how far it is spread from the organ of sight. So the first thing that would usually happen if someone has been unfortunate enough to have a prostate cancer is that we would have a discussion about the grade. The lower grade of prostate cancers, thankfully, are relatively slow growing and can often be managed with an active surveillance protocol, but higher grade disease will definitely require some intervention. And most people, if they haven't had an MRI beforehand, will have what we call a staging MRI. And occasionally a urologist will recommend a bone scan, but that's usually in the situation when the PSA is extremely high, above 20, and when the Gleason grade or the aggressiveness of the disease is very high. An MRI helps confirm that if we have identified a cancer, that it's confined to the prostate gland. And what options, therefore, will a urologist speak to you about if you are unfortunate enough to be developed by prostate cancer? Up on the left-hand side there, I put up that slide and I'm talking about active surveillance. We now recognize that some of the prostate cancers are so slow growing that they may never cause a problem for 10 or 15 years. And that perhaps by following someone's PSA over that period of time, if their PSA were to go up, you might do a second biopsy, you might do a further MRI, but that we know that by actually following people that closely, the prostate cancer may never cause them any harm at all. This was originally popular, obviously, in older men between the age of 70 and 80 with a lot of other diseases, be they heart disease, but it's increasingly being offered to younger men now between the age of 55 and 70. It doesn't mean no treatment. It means close observation over a long period of time. It's offered to patients. They don't have to take it up, but it can be a good way of not causing any harm. Other treatments that are popular, if the disease is a little bit more aggressive, would be radiotherapy. And that can be given either as an external beam where the patient visits the hospital half an hour a day, 5 days a week for 6 weeks. And the radiotherapy is administered into the prostate and kills off the prostate cancer. It can also be administered with little seeds. That's called brachytherapy. That's a day case or one-night procedure. Radioactive seeds are placed into the prostate gland and they decay over time. And that radioactive radiotherapy treatment will again kill off the prostate cancer. And of course, there's always surgery, which is removal of the whole of the prostate gland. So we've spoken about active surveillance. We'll go on to the next slide. We've spoken about radiotherapy. There are side effects associated with it. There are namely that they alter the lower urinary tract symptoms, that they can cause a little bit of bleeding from the back passage, and they can cause a little bit of shrinkage of the bladder and occasional bleeding from the bladder. But as long as the patient recognizes those symptoms, they're not so bad. Brachytherapy, which is the little pellets put into the prostate, has the same side effects, but the advantage of it is it's just a one-day procedure as opposed to 6 weeks in the hospital. Again, there are pros and cons, but I don't want to go into the details of why someone would have external beam or brachytherapy. And increasingly now with surgery, most people are being offered robotic prostatectomy. It's a minimally invasive technique. It definitely reduces the risk of blood transfusion. And there are many proponents who suggest that it can reduce the risk of the specific side effects of erectile dysfunction and urinary incontinence, which any man facing a prostatectomy has to take on board. But they will be, your surgeon would discuss those with you in detail. Go to the next slide there. And there are newer technologies that you may have heard about, such as HIFU. They're not as well validated as radiotherapy or robotic prostatectomy or active surveillance, but they remain interesting and we keep them under close observation. So HIFU is a high intensity focused ultrasound. It's passed through the rectum, which doesn't cause any damage to the rectum, but it can occasionally in specific cancers potentially reduce the size of the cancer within the prostate. But at this stage, it probably is more of an experimental procedure than the other procedures. So in conclusion, I would say that BRCA, usually if I'm asked by a patient, be they male or female, and they're worried because their sister or mother has had a breast cancer and knows whether they're BRCA1 or BRCA2, I would say that the increased risk is quite small as far as we understand at this time, not to get overly concerned. But if they are concerned, the best thing they could do is get a PSA blood test. And if it's elevated, they can go and see a GP and urologist who will do an MRI and consider them for a biopsy. So thank you for your time, and we're happy to take any questions later on.
Thank you very much, Killian. Well done. It brings me back in time, prostate cancer and biopsies, all sorts. So moving on, I'd now like to introduce Dr. Deirdre Forde, who is going to talk to us about managing menopause and has a very special interest in that. So Deirdre works as a GP and has a particular interest in menopause and women's health, having gone through it herself and that transition in her early 40s. So she's a retired GP now after a very successful career. She's very proactive when it comes to preventative medicine, and so has the skills to help you achieve your optimal well-being potential from a holistic perspective. Deirdre has recently been appointed to one of the regulatory committees of the Irish Medical Council and graduated from NUI Galway in 1984. So Deirdre is going to talk to us today about her passion, and that's menopause. Welcome, Deirdre. How are you?
Good, Helen. Thank you so much for having me speak today. I'm really excited about educating women about menopause. So, ladies, thank you for joining us here today. So I'm just going to very quickly go through menopause and I'll answer any questions at the end. So let's consider premature, early, perimenopause and postmenopause. We look at hormones and breasts and the facts around all of that. Very importantly, menopause symptoms, menopause treatments, hormone replacement therapy, and then briefly we will look at andropause, which is the equivalent of the male menopause. So this slide really just demonstrates that every woman is different, so the treatment options are different, and unlike any other medical conditions, menopause treatment can be tailored to consider your lifestyle choice, including alcohol and cigarette use, your age, your past medical history, and your family history on the best way to manage your treatment. So the causes of menopause then differ, and we are looking at, am I too young to be in menopause? So women who are under the age of 40, for whatever reason going into menopause, usually a risk reduction surgery, premature ovarian failure, or surgically induced for some other reason. These women are having premature menopause, and these are the ladies who are at increased risk of ischemic heart disease. So you're talking about heart attacks, osteoporosis, and early dementia without adequate HRT treatment. Early menopausal women then, their risks are their causes are similar, usually surgically induced. It could be a natural transition where there's been family history or mum went through it early. Or I have found that possibly it could be stress related by having children at an older age. And I've certainly come across some of those in my clinic. The perimenopause, then, this is when women are actually transitioning towards natural menopause, and this is where the symptoms are actually most severe. Women are still getting their periods, but they're very erratic. And women may be misled by some GPs by saying that because they're getting periods, they could possibly be menopausal. So with regard to our risk of breast cancer, these are the facts. There is no direct evidence to show that HRT transforms benign breast cells into a high-risk pre-malignant condition. HRT is not a carcinogen, but what it may do is, in fact, bring a stimulatory effect on an existing cell to become palpable in the breast. So do remember that it takes about 8 to 10 years for a breast cell to change from that small pre-malignant state to be clinically detected in the breast as a small lump. Now, every woman's risk is different. So estrogen alone is very beneficial, and it reduces the risk of breast cancer. Estrogen with progesterone, there is a small associated increased risk, and we will discuss this actually in a graph that I'm bringing up shortly. Thank you. So the benefits as opposed to the risks. We really need to have a look at our improved quality of life. We need to have a look at our protection against osteoporosis and our protection against ischemic heart disease. So these two are the protection against ischemic heart disease and osteoporosis are very important for women. We are actually outliving our ovaries, and at the end of the day, we must consider our quality of life when we're assessing our risks. Now, this has been an interesting slide, and it was at a previous conference that I was with, but basically showing other risks associated with breast cancer. If you have a look there, 400% use with electric blanket. There was another one I was looking at. It was the use of grapefruit, increasing it by 30%. Any questions you have in relation to that, I will ask at the end. Okay, so I think Terri and Reem have already gone through this, so I'm going to pass on that one. All right, so these are our options. We can have estrogen-only HRT, and this is suitable for women who've had a hysterectomy or women who have a Mirena coil in situ. There's no associated risk of breast cancer. We also have combined HRT, and this is for women who need that progesterone to protect the lining of the womb. If we do not have protection against the stimulatory effect of estrogen, we're at increased risk of the lining of the womb becoming very thick and the cells starting to change, and then we develop an endometrial cancer. Next slide, Helen. So, our next slide.
Problem there now. Bear with me a minute.
All right, so this leads me into actually the symptoms of menopause. So beware the menopause fairy, and this is all very true. She steals your figure, she steals your sleep, your mood, your patience, your eyesight, and then eats your brain. And then you've got this increased skin, you've got brain fog, and you've got itchy skin, and you have this endless need for sleep, coffee, wine, and carbohydrates. So our symptoms of menopause. The most frequent ones that I actually see coming into me are hot flushes and these drenching night sweats, and we're talking about sweats in between your breasts that wake you up at night time. Insomnia, you can get to sleep, but you're awake at 3 o'clock in the morning. You're going to the loo because you've got this urgency to go, and if you don't go to the loo, you're actually going to wet yourself. You have this stress incontinence, meaning that if you've got a cough or you're running, you start to leak. That's called a stress incontinence. If there's terrible anxiety associated with palpitations, not feeling yourself, loss of libido, relationship difficulties, there's actually about 34 symptoms of menopause. So this is a slide taken from my surgery, and this is the first thing that women see when they come to reception, and it's exactly typical of menopause. What am I doing here? I can't remember what I've come here for. So it's that brain fog and memory loss. Next slide. We'll skip over that one. Terri said, now this slide is very important. This is understanding the risks of breast cancer and what you can do to reduce your risk. So this is, these are UK studies, and they're for women over the age of 50 to 59. So it is a fact that 23 cases of breast cancer will be diagnosed in the UK per 1,000 women over a 5-year period over the age of 50. For women who are on a combined HRT, which is estrogen and progesterone, that risk is going to increase by another 4. But for women who are on estrogen-only HRT, your risk is reduced by 4, so estrogen is protective. But looking at the risk of the HRT, it's the same risk as being on the pill. It's more or less the same risk of somebody who smokes, but the risk starts to increase in women who drink 2 or more units of alcohol a day, and the risk also increases with women who have a BMI over 30. Looking at these risks, and I'm looking at the HRT, combined HRT, if you reduce your risk, if you reduce your consumption of alcohol, and if you take exercise every day, you have now reduced your risk of breast cancer in using that combined HRT. So that is just doing it again. HRT is a really good hormone, basically hormone replacement therapy to protect you against osteoporosis, heart disease, and dementia. And you need to do your 2 hours per week of exercise. You need to limit your alcohol daily. You need to reduce your smoking. You need to exercise and get your weight back down. And this is another one, again, to say, please, if you're drinking every day, you really, really need to stop that to reduce your risk of breast cancer. Now, just our products here very briefly. We've got tablets, we've got patches, and we've got gels. And our tablets are, because they've got an increased risk of causing a pulmonary embolus or deep vein thrombosis, that is clotting issues. It's not for smokers. It's not for people who use frequent airline travel. Not for people who have blood pressure issues. You can have HRT once your blood pressure is controlled, but you're ideally going to be on a patch or a gel. The oral tablet is not for overweight women, and it's not for those with liver issues. The only positive about it is it's the cheapest option. And with patches and gels, they're so much safer. They don't go through the liver, they're absorbed through the skin. The gels are wonderful. You just put it onto your skin, onto your upper arms every single day that you soak in. And the patches then are changed every 3.5 days, and you put them on below your belly button. More expensive. The patches are about €30 a month, and on top of that, then you've got to add in any progesterone if you need it, because not every patch has a progesterone in it. So the next slides will just show so these are our other HRT. So we're talking about our progesterone. So the best one really to use is either the Eutrogestin or the Dufaston at night time. The Eutrogestin is considered very same progesterone as your own body progesterone. It's microionized progesterone. So you take it at nighttime because it has a calming effect, a relaxing effect, and you would sleep better. And progesterone needs to be taken for those women who have a womb to quieten down the stimulatory effects of estrogen, as I've said already. There is only one patch that contains both the estrogen and progesterone, and that's Everol Conti. Otherwise, you have to take a tablet at night time. There's also testosterone sachets or pumps or androgen cream. These are expensive products, but really, really good to deal with your loss of libido and to increase your energy. I just briefly want to talk about local estrogen. Local estrogen can be given to every single woman, even those ladies who've had a breast cancer, because this is a local estrogen. It's not systemic. It won't go into your blood system. However, in saying that, those women who have vaginal, I suppose, atrophy in terms of their cells are so limited that they start using Vagifem or Invages, there may be a small risk in the initial stage that it could transfer into the bloodstream. So every woman needs to be assessed individually in terms of that. They're really good. They will reduce your risk of urinary tract infections, also in terms of helping you with that stress and that urgent continence. Next slide, please. Testosterone, you can keep going with that. That's all about what I discussed there. Okay, so these are just our products. The tablets, Femistan. If you see something like a 210, it means you're on a product that is going to cause you to bleed because you have been less than 12 months since your last period. If you see something like a Femistan Conti, that means you're on a continuous because it's 12 months since your last period. Livial is a great one. It has estrogen, progesterone, and testosterone, suitable for women only who have had their last period over 12 months, but very good in terms of libido issues. Okay, the next one then shows just the patches, Estradiol. These are all estrogen ones, and the only one that has a combination one is Everol Conti. It has the progesterone in it. Slide. And these are the gels. You've got Baby Gel that you put onto your upper thigh every morning. You've got an estrogen pump that you put onto your upper arms every day. We've got Androfem, which is the equivalent of your female testosterone. You put that on your thigh every day. Or the Testrogel, which is a sachet that men use. Men in their male menopause would use maybe 1 sachet a day, but women use a 1/7 of that, so a pea-sized amount. And then you can see our Invages, which is butter for the vagina pessary that you put in at nighttime, and and our Vagifem, which is an applicator. Okay, briefly, andropause is actually the male menopause, all right? So looking at these two men here, very similar to a woman who has a deficiency in estrogen. The man who's got a deficient testosterone level is going to be depressed, constant fatigue, increased body fat, increased risk of erectile dysfunction, low libido, increased risk of osteoporosis and of Alzheimer's disease. Next one. So the male menopause is actually a very misleading name because it's not really the sudden drop of testosterone. There's certainly testosterone can be one of the issues, but there's a lot of other issues which cause this male menopause. Next slide. So a lot of the male menopause issues can be lifestyle factors or psychological problems such as stress, anxiety, work-related issues. They may have this midlife crisis, which they think that they have reached the halfway of their life stages, and at this stage they've got this lack of sleep, poor diet, lack of exercise, drinking too much alcohol, smoking, and low self-esteem. Hypogonadism, which is where you have reduced production of testosterone. This sometimes presents from birth, but it causes symptoms like delayed puberty and small testes. But hypogonadism can also develop in later life, particularly in men who are obese or have a type 2 diabetes. So these men may in fact have a low testosterone level. Next slide. So similarly, again, similar to the woman, mood swings, irritability, lack of enthusiasm or energy. They have difficulty sleeping, poor concentration and short-term memory. They have this fatigue. Physically then, they have a loss of muscle mass and they have a reduced ability to exercise. They've got fat redistribution, so they've got these man boobs or gynecomastia. They have large bellies. They've got loss of libido and erectile dysfunction. So again, what do we do if a man is displaying these symptoms, especially the overweight, maybe type 2 diabetic? First of all, the GP, do a lifestyle assessment. Are there any anxieties? Are there any stresses? And do the blood work, including testosterone levels. So cognitive behavioral therapy could be very useful for these men, or if they need a testosterone replacement, they're going to use a testosterone supplement like Testrogel 1 sachet a day, or the Testrogel pump. They may also need the Viagra or the Cialis for their erectile dysfunction. So you will also get information on the British Menopause Society. It's very informative. You'll get some nice leaflets there if you want to have a look at that. And finally, we are in a situation of COVID-19. I am a GP. I still do some GP sessions. I ask you to stay at home, stay safe, adhere to the HSE guidelines, and please do not be afraid to see your GP. If you need to see your GP, our surgeries are very quiet. You will be safe and your GP will see you. And you can also get remote consultations through Ceile Medical with a script to your pharmacy. Thank you very much.
Okay.
I think, Helen, we're up with the next speaker.
I'm here. I can't seem to get my video back on.
You're on, Helen, so you can take it away.
Pardon?
You are on, you can take it away.
Okay, thank you very much. Deirdre, thank you. I was just saying, like, you've actually said something really important in your last slide for our audience. Please do not be afraid to contact your GP at any point in time. They are still available to see us with any problems outside of COVID. So thank you for that. Next up, I'd like to introduce you to Abaigeal Jackson. I know Abby quite well. We work together in the peer-to-peer volunteer group. So Abby has become one of the 7 ladies who is involved in our peer-to-peer support for women and men in Ireland with BRCA1 or BRCA2. Abby was diagnosed at 32. She's completed all her surgeries that you've heard about this morning in terms of risk reducing surgery for breast and ovarian cancer in 2017. She's living really well. She's a wife and a mom to 3 boys and lives in Dublin. And I'd like to introduce Abby now to tell us a little bit about the peer-to-peer support group, to tell us a little bit about herself, and then to inform you as to how you can actually you know, have this service or access this service.
Helen, thank you so much for the lovely introduction. And can I just say it's been wonderful hearing from all the experts this morning. I think as somebody who's lived through this experience, it's really reassuring to see that there are people who are behind us and helping us live our best lives, for want of a better phrase. I'm going to talk today a little bit about the peer support service that is offered by Mary Keating, and as Helen indicated, I'm one of 7 volunteers. I'm going to talk about those and the service now in a minute. I suppose, given that we're living in the COVID-19 crisis and we're living through it right now, it brings home to us really just how important support is to us. And when that support isn't there, you know, we can see how it can impact us. And this is a picture actually of myself and my family doing a Zoom call the other week for my son's 7th birthday. And it's things like that that really give you the boost and the support that you need during difficult times. And much like COVID-19, I think anybody who's going through the BRCA experience now and making their decisions and coming to terms with their diagnosis, and also those who are on the other side of it, still need support. And I think, you know, that's one of the main drivers that support might not have been there for many years, but it's really reassuring again to hear from everybody and Dr. Salman at the start saying that there is progress being made, and that's really reassuring. So I want to start and talk a little bit about how this has all come about. Roisin Prizeman was mentioned a little while ago as one of the, I suppose, initial, agitators in this space to get better support for families, men, women, and families who have a BRCA1 or BRCA2 mutation. And with Mary Keating's involvement, there was a peer support group established following the very first BRCA conference, I believe in 2018. And really, as I say, this was off the back of there being very few BRCA supports. And, you know, when you're going through it, you feel like you're very much alone. I remember my own experience of receiving my diagnosis and going through that whole screening process. And I recall very clearly going to Crumlin and going through the genetic counselling. And, you know, I have to say the genetic counselling service there was second to none. But one of the things that still sticks with me is that when I left the clinic that day after receiving that diagnosis, I walked out of there with a yellow post-it note with 2 websites on it, and that was it. And I had to go and make my decisions. And there was no support services there at that time, and I think maybe many people can, that might resonate with people. And those, 2 websites were to UK services as well, and to UK websites, and I didn't really know if they were relevant to me. And when I did look at them, they didn't answer the questions that I had as somebody who's living in Ireland, who's trying to access Irish services who aren't the same as in any other country. So, I'm happy to hear that the National Cancer Care Programme are doing some work in that space as well. So we look forward to things that are happening there, and hopefully will come to fruition soon. So Mary Keating, as I mentioned, are the first and only charity to hold an annual BRCA conference, and I'm really grateful to them for that. It's great to have a space for us all to come together. They have created a BRCA information section on their website, and you can see that up there. And also there is now a support service that you can access through the website. And I'm sure after this presentation, you know, if you do have time, go and have a look at the website. And I'm sure that if you don't have that information, you can follow up with Mary Keating and they will direct you to that as well. So I want to introduce you to the 7 peer supporters. That's myself on the left. Then we have Nikki, Aoife, Melissa, Aisling, Roisin and Terri. And this was a picture taken of us in January. And, you know, one of the really beautiful things that has happened as a result of this pretty awful situation is that we have a community now, and we have a great friendship and a great support system amongst us. And I hope that extends to everybody who's attending here today who's affected by BRCA as well. I think what we would like you to know is that you're not on your own and you don't need to be on your own, and that if you do want to reach out, whether you know what you want to ask about or talk about, it doesn't matter. We're here and we're more than happy to talk to you about, I suppose, our lived experiences and listen to yours and be that listening ear. We have received training from the Mary Keating Foundation as well around how to offer you support. So you can rest assured that we will be doing our very best. And I suppose I just need to point out as well that we're not providing medical advice. It's a peer support service, so we can talk about our own experience and really just support you emotionally, I suppose, going through this. So if we go on to the next slide, I think this is what we're going to look like after we get through the COVID-19. There's a lot of complaints about grey hair, so we really hope that this lockdown will end soon. So if we move on to the next slide, I suppose the areas of peer support, we are a diverse group. We have members who have the BRCA1 mutation, BRCA2 mutation. We have members who have gone through cancer and then have discovered that they have BRCA. And then we have people who haven't had cancer and who have learned that they have the mutation. And they're based all across the country. We're aged from 22 up, and I suppose we're at different stages of the process. There are some of us not yet even in the surveillance stage, but know of our mutation. And then there's others of us that have gone through the breast surgery and the gynecological surgery as well. And really, the fact we're all females, we're quite cognizant that this does not affect just women. I'm delighted to see that Professor Killian Walsh was talking today. But this just reflects, I suppose, the fact that there were just women who volunteered for this service. So if you are looking for some support in the areas of, you know, surveillance and experiences, I want to talk maybe through your experience of breast and ovarian surveillance. We can support you with that. We can talk to you about preventative mastectomy, you know, the experiences and options for breast reconstruction or none. The surgeries for removing the ovaries and fallopian tubes. I suppose the surgery and going into hospital can be quite daunting, and how to navigate the health system, the healthcare system is daunting, but I'm hopeful that it's improving all the time. Issues around fertility are really important, around HRT, as we've heard, sexual dysfunction, and talking to, you know, I suppose even thinking ahead, we're kind of, this is open to tin of worms, I suppose, with people now knowing that they have this mutation, and people have to learn and figure out how to talk to their own siblings and family about it, and their children as well. And that's, you know, increasingly, you know, a theme that's becoming increasingly common, I suppose, and also work-related issues too. So we go on to the next slide. This is the webpage that you can access if you want to get some peer support. So if you go into marykeating.ie, and under the Cancer Services tab, which is highlighted in purple here, there's a drop-down list, and you can select the BRCA section there. If you go on to the next page, there is a form. There's some information on this page all about BRCA, but there's also a form that you can fill out if you want to request support, and you can fill in, and on the next slide you'll see some of the detail. You fill in your name. Don't forget to provide some contact information, either a phone number or an email address. You might want to indicate what kind of areas you're looking for support in. Because we are a diverse group, some of us will be better able to speak with you about certain areas, And what will happen in the background is the nursing team led by Helen will review your queries and will decide whether they need, I suppose, guidance and advice from a medical professional, and if not, it'll come to one of the 7 peer supporters and they will match your query with one of the volunteers. And maybe if you can indicate as well, when is the best time to contact you. Now, please bear in mind if you're using this service that you won't necessarily have an instantaneous response. There's a little bit of work that has to go on in the background to get you in contact with the right person. So please just bear with us while we get to that, but we will be in contact with you as soon as we possibly can. Okay. So it was really great to hear as well today about lots of research that's going on in the BRCA area, both here in Ireland and in the UK. And I suppose I just wanted to highlight one particular project that is being done by Nikki, who is one of our youngest peer supporter, our peer volunteer. Nikki is undertaking a PhD in psychology in NUI Galway. Her study is about looking at experiences of people since they have been identified as being a BRCA1 or BRCA2 mutation carrier. And what she's hoping to do by undertaking this research is hopefully to create an online support tool to help people that have a BRCA mutation cope and process the news in a healthy way. And so this is a picture of Nikki here, and really there's a shout out, I suppose, today. Nikki is looking for some volunteers to participate in this study. She's looking for individuals that have learned of their BRCA mutation status in Ireland, so who've gone through the Irish healthcare system. She especially at the moment wants to hear from men who have a BRCA1 or BRCA mutation. So if you are a man online here and you're interested in participating, or you are a woman who knows of men with BRCA1 or BRCA2 in your family, you might put this information in front of them. They might be interested to participate. What Nikki would like to be able to do is to conduct an interview, which lasts 30 minutes to an hour over the phone, really at a time that suits the individual. There is contact information there for Nikki as well. You can email her or phone her. And again, these slides might be available afterwards, and you can use those to contact Nikki about those. I suppose I've kind of gone through the majority of issues that I wanted to cover today. I really just wanted to say a special thanks to the Barry Keating Foundation for supporting the BRCA community in Ireland, and for all of the experts who've participated on this in the conference and the webinar today. It is such a weight off shoulders, I think, to have, well, to know you're not alone, and that there are other people out there, and you know that there is support if you want it. So, you know, quite honestly, when I got my diagnosis in 2013, there was nothing there. I had to make my decisions really in a bit of a vacuum. But our volunteers want you to know that you don't have to be alone if you don't want to. I don't know if I would have reached out to ask for support back then. I was very strong-headed, but I can safely say, knowing the women that I know who participate in this scheme, I would have really missed a trick if I hadn't reached out. And they have really, you know, made my life an awful lot easier, and made this journey so much easier because I know I'm not alone. So thank you so much for your time, and I'll hand you back to Helen.
Thank you, Abby. It was lovely to hear your story. I'm sorry that you had to go through that, but it is lovely to hear your story, and it's lovely, I suppose, to know from you as a person that this support has been probably invaluable to you, and will be for many people listening today if they want to link into that. It's always difficult to share your story, but thank you. I really appreciate that. So I think we've got ourselves back on track in terms of time. I suppose now what we would like to do is open up a discussion and a Q&A with our panelists, and with Eoin, Hanney and Claire Giffney, who I'll introduce to you now. So Eoin is a registered genetic counsellor. He trained at Cardiff University before spending 5 years working as a genetic counsellor in Scotland. He has been working as a cancer genetic counsellor in Blackrock Clinic for almost 2 years. So Eoin would very much be able to answer questions around, I suppose, genetic testing and counselling in the private sector. Then Claire is a registered genetic counsellor working in the Cancer Genetic Services in St James's Hospital. Claire has completed her Masters in Genetic Counselling in the UK, following which she spent several years working in cancer and general genetics in the NHS before returning here to the Irish Health Service. So Claire has a keen interest in genetics education. She delivers genetic counselling and training to oncology teams as part of a national project introducing BRCA testing to the oncology setting, and is involved in developing patient literature around hereditary cancers. So it's great to have those kind of resources and experts as part of our panel. So we're now going to do a Q&A with our panelists and our genetic counsellors. So I'm just going to pull up the Q&A. Hello everybody again, it's nice to see you all.
Hello.
Hi.
Okay. So what we'll do now is we'll read out the questions. Lots of questions have come in, which we're really pleased to say, so it's been very interactive. So I'll read them out and I'll see if I can direct them, but if anybody wants to take one that they feel they can answer really well, that'd be great. So here we go. Thank you all as well in the audience for putting your questions through. We have 36 questions there, which is fantastic. So some people have put their names down, some people haven't. So the first question I think here will be to Terri. Does removing the fallopian tube instead of ovaries work as risk-reducing surgery option for women testing positive for mutations of the BRCA gene?
Very good question, and really the jury is out as yet. So the biological rationale behind that is that we actually think that the cancer that we call ovarian cancer, what we believe is that actually the vast majority of those cancers start in the fallopian tube. So the rationale behind doing the fallopian tube surgery is that if you take out the fallopian tubes first, you reduce the risk very dramatically. But what we're not sure about is what proportion of the risk is left then in the ovaries themselves. So that's what the Protector study is looking at. They're trying to see, can it safely be done as a two-stage approach where you do the fallopian tube surgery, you know, after the age of 30 and leave the ovaries in situ to go back closer to the menopause to take out the ovaries. So that study, the way it's set up is that they're actually looking at things like hormonal levels and the symptoms of menopause and sexual function and things like that. But obviously, as a secondary kind of outcome, they'll be looking at cancer rates and things like that as well. So we're waiting with bated breath really for the results of that study, because obviously, if that's a safe approach, it'll really change the way that our younger women are managed, because obviously that's the biggest issue at the minute, is having those ovaries taken out so young. At the minute though, strictly speaking, based on our guidelines, the only proven way of minimizing the risk of ovarian cancer is to have both the fallopian tubes and the ovaries removed. So any surgery that involves just the fallopian tubes first should really be done within the context of the research study.
Okay, excellent. Thank you, Terri. Okay, so we've got a lot of questions here, so we'll go through them. The next question is, why is the risk higher with BRCA1? Now, who would like to take that one? Terri again.
I'll probably take it. So it's to do with the function of BRCA1 basically. So it's all to do with the DNA repair pathway and how it's set up. So BRCA1 and BRCA2 participate in this pathway called homologous recombination, and BRCA1 is really the main player then. BRCA2 is very important, but certainly your BRCA1 is the main player. So if your BRCA1 is lost, that homologous repair pathway doesn't work quite so well. BRCA2 is it also participates in another DNA repair pathway called non-homologous end joining. So this is getting very complicated now, so I'm not going to go into it in too much detail. But basically, it's just because they work slightly differently in terms of DNA repair. So very closely linked, but certainly BRCA1 is your main player in that repair pathway. And that's why when you lose BRCA1, you're at very, very significantly increased risk of cancer. What isn't so well known is why the cancer types are the types they are, and that's even more complicated and to do with gene expression in those different tissues and things like that. Why BRCA2 is more severe or more increased risk in men is probably to do with that. So BRCA2 is a bit higher for men, but BRCA1 is a bit higher for women. But it's science stuff basically. Sorry, not to simplify it too much, but it's a complex question. So I think we'd be here all day if I tried to answer it comprehensively.
We might take that offline, Terri. Okay, another interesting question here, and very pertinent, I'm sure, for young families. At what age should I have my children tested for BRCA? Who would like to?
Sorry, I'm jumping in all the time. We don't recommend testing in childhood, and the reason for that is that the risks in childhood is not increased as far as we know, apart from very unique families where there's 2 BRCA mutations running in a family, and that's a different disorder completely called Fanconi anemia. So children that are at risk of just inheriting 1 BRCA alteration from a parent really don't encourage testing in childhood, because if you find out your child is a BRCA carrier, you're not going to be able to do anything until they're 30 anyway. And by the time they're 30, they'll be an adult and they'll be in charge of their own health. So really what we're trying to do by deferring testing until adulthood is preserving the autonomy of the child, you know, and obviously parents are just doing what they think is in the best interest of their child. But if we're doing a test, it's for the person's health, you know, not for you. So parents, I think, ask for it because they want to be reassured that their child hasn't inherited it, whereas we're approaching the test assuming that they have. Because if you assume they have, you know, the only, assume the worst and you'll never be disappointed is what my dad always used to say. But we don't do it just to reassure people. So really we leave it until the child is able to make decisions for themselves. Some children are very mature and able to make that decision at 18. Other people are not able to even comprehend testing until much later in adulthood.
Okay.
Another message I want to add is, even if you tested positive, there is no guidelines will offer you any screening earlier than the age of 30 at this stage. It might come down until by the age of 25, but there is no screening test for you to be done before the age of 30. So knowing it before the age of 25 is not going to be of making any difference.
Okay. And can I ask the panelists, like maybe Claire and Eoin, what is the age range of patients that you see, generally speaking? Maybe Claire.
Yeah, so I suppose Reem has highlighted there that there isn't any screening in the early 20s. I suppose we do see some people who might come from the age of 18 or in their early 20s, because for them living the not knowing can sometimes be more challenging than actually finding out their status. So I suppose our goal, and Eoin will probably agree, is really to guide them on when the right time for them individually is to be tested. And as long as they understand that there isn't any screening until they get to 30 usually. So I guess it's complex. People come for testing for lots of different reasons. And I guess it's about really supporting the patient to make a choice that's right for them. So if someone chooses at 19 or 20 to have a test and they've really thought about it, we will support and guide them through that.
Okay. And would you have anything to add to that, Eoin, in the private sector? Does it change anything?
Not really, but I think for me, when younger women come to ask about testing, you know, maybe under the age of 25, I probably kind of deal with them a little bit differently, in that you would kind of take things a lot slower and make sure they fully understood all of the implications of having the test, and that they knew that, you know, there are no things won't change. And again, I think it's a very delicate time in people's lives. You know, they've got a lot going on with university or work and things like that. It's a delicate stage of their life. So we probably have kids' gloves on a little bit when we're dealing with younger people. But I think that's where genetic counselling can be very important, in that, you know, we can have discussions around the testing without actually saying you need to have this test right now. So I think that's something to think about as well, is that, you know, genetic services aren't just about going in and having a test. It's the talking about all of that as well around that, and the genetic counselling can be really important for that.
Okay, thank you. And Abby, can I just ask you as a mother how that feels for you, you know, in terms of testing your children?
It is obviously a concern. You kind of speculate, don't you, in your quiet time as to what, you know, what the outcome will be for your children. And I certainly remember when I was going through my own testing, I remember actually receiving the phone call to say that, you know, I needed to come in, and they had the test results, and I had my 1-month-old infant in my arms, and, you know, it was quite a jarring experience. I think you're getting a call, and my sense was that I had it. I was quite confident I had it, and I'm looking down at this little infant going, God, what have I done, you know? And it's scary, and it kind of makes you think as well about, you know, as a woman with my parents are alive, and how they feel about passing it on to me as well. And, you know, although when you go in and you speak to a consultant and a genetic counsellor and you're treated as an individual, the ramifications are much wider. It's a family-wide thing, you know, and you know, your father and your mother, how do they feel about it? And I don't think my father would mind me speaking about the fact that it came from his side of things. I think it was really, really hard for him, you know, and he felt guilty about that. And, you know, if I don't feel that, I kind of say, well, look, you know, haven't I lucky? But, you know, it just kind of goes to show that it's a difficult one, really. It has a lot of things associated with it.
Thank you. And Killian, just we talked about Abby's father there. Are you having much experience of men coming into your clinic asking for the BRCA test now?
Yeah, occasionally. It's not a frequent request, but I'm trying to reassure them and calm them down. I think a lot of it is maybe via the media, they're picking up on things. And I think Terri alluded to that study that perhaps there's a small cohort of men between the age of 40 or 50 who might be worth getting their PSA checked a little bit earlier. But most men that I see, I reassure them and say, look, the risk is small. Let's start by a digital rectal examination and do a PSA and leave the BRCA thing to one side for the moment.
Yeah, good. Okay, so our next question is from an anonymous attendee as well. I'm 34 years old, BRCA1 carrier, and had prophylactic bilateral mastectomy when I was 29 years. I am family complete and would like to know what age is recommended for prophylactic oophorectomy. Will you take that one, Terri?
Yeah, so she's 29 now, is she?
She's 34 now.
Oh, 34 now, yeah. So I suppose you need to know a little bit more about her family history. Like the oophorectomy would certainly be considered from 35. As I said, we tend to kind of push it closer to 40 for our BRCA1 carriers, but you need to kind of weigh up for yourself the risk benefit of the, you know, premature menopause versus the risk reduction overall. So certainly 35 is a good age to start thinking about it. We tend to push it out towards 40, but it's, you know, we do consider it between 35 and 40 as long as people are aware that there are those associated health risks. And of course, Deirdre really nicely went through all the different options for managing those risks. And if that person doesn't have a previous history of breast cancer, then they would be very viable options for her to help mitigate the risk of a premature menopause. So I certainly think now is a good time to be thinking about it. But if you want to take a couple of years more to think about it, that wouldn't be irresponsible, you know, to kind of take a little bit of time to think about the potential ramifications of it and consider your different options.
Okay, thanks, Terri. We have another question here from Anonymous. I have been diagnosed with BRCA2 mutation last November. After having seen the genetic counsellor, gynae and breast specialists, I have received 3 different opinions on what I should do, especially about the timing of when to remove my ovaries and whether I get HR treatment or not. I have my operation scheduled soon, but the insecurity of how my menopause will be treated is putting me off. What do you advise and how should I move forward? Maybe Terri and Deirdre might be able to answer this one collectively.
I don't know, well, I'll leave the menopause management to Deirdre. Obviously, like we can only kind of speak to what the guidelines are, and you know, with the best will in the world, people should be working off the same guidelines, but I suppose it depends on the personal experience of the doctor that you're dealing with. It also depends broadly on your family history as well. So I would hope that the advice that you're getting from your genetic counsellor is based on your family history and taking into consideration your specific genetic alteration, right? Whereas depending on the level of expertise of your surgical team in dealing with BRCA carriers, if they're reading straight from a guideline, they may be advising you slightly later. If they've had negative experiences with BRCA carriers developing very early surgery, they might have a personal bias to recommending things a bit earlier. So it's very context specific, and I do know that's not an unusual story at all, that people come in having received different opinions from different people. And I think this is where arming yourself with as much information as possible so that you can have a kind of a balanced discussion with your providers, because the nice thing about health providers is that they're very open to being, you know, to questioning discussion. You know, it might be a case that your surgeon needs to give a quick call to your genetic counsellor and say, well, look, why is the rationale, why are you saying a different thing from what I would recommend? This is based on my expertise. This is, and you might find it's something very simple that has triggered that kind of difference of opinion. You know, and it may be one person is using a UK guideline, one person is using a US guideline, because as Reem said earlier on, there unfortunately isn't an Irish guideline. So it very much depends on where the people are drawing their guidance from. You know, so it sounds like it's such a simple thing that everybody should be singing off the same hymn sheet. But if we don't have a national hymn sheet, that becomes very difficult, you know.
Yeah. Okay. Do you want to add in? Do you want me to repeat the question there? Or are you okay?
Yeah, if you wouldn't mind, please.
So the second part of it is about, especially about the timing of when to remove my ovaries and whether I get HR treatment or not. I have my operation scheduled soon, but the insecurity of how my menopause will be treated is putting me off. What do you advise and are on how I should move? What do you advise on how I should move forward?
Well, absolutely. I would say that, as Terri had said, also that she probably needs to have this discussion with, you know, with the specialist, either if it's her GP who knows her own history, or if she wants to see somebody in terms of, you know, a HRT specialist, a menopause specialist, because as I said, every woman is different and their history is different. So it's very hard to say, but definitely her menopause can certainly be treated without a shadow of a doubt. That can be treated and her symptoms can be alleviated. So she shouldn't need to worry about that part of it.
Okay, thank you.
Alan, could I come in for a second?
Yeah, please do.
I think there can sometimes be, it's a common question that comes up, or a common thing that comes back to us a lot of the time, is that women struggle to get HRT after having a risk-reducing oophorectomy. And that might be because their health professional maybe hasn't dealt with a BRCA case before, hasn't seen a woman with BRCA1 or BRCA2 before. So I think the important thing is, if that resistance, you know, does come up, get that clinician to get back in touch with the genetic counsellor that they've seen, or somebody, so we can give them the information. So I think that can be quite a common thing that does come up, but, you know, feedback to the genetic counsellors, and we can give information to other health professionals to kind of let them know about that.
Okay, brilliant. Thank you.
Yeah.
Okay, so another anonymous attendee asking a question. It says there is an increased risk of heart disease, dementia, and osteoporosis after ovaries being removed. What is the level or rate of this risk? Would you like to take that?
Deirdre's probably more well placed to address it, but I think it's, again, it's sort of an individualized risk that you need to talk about, because all of those factors, you need to consider other risk factors, things like smoking history, family history, all of those kind of factors. But there's a huge, like a real wealth of research out there. There was a large Danish study a few years ago looking at, you know, dozens of thousands of nurses, looking at people that had had premature menopause, either because of natural reasons or because they'd had a surgery, and the increased, particularly the risk of heart disease, the increase in risk was up to 40%. Now, the difficulty with that study is there was quite broad, what we call confidence intervals. So you'd see variability in the level of risk increase based on other risk factors like smoking, weight, all of those other things. So it's sort of difficult to quantify in broad terms, but certainly we know the risk is increased, and the level to which it is increased depends on the other risk factors, basically. Is that fair enough to say, Deirdre? Sorry, I hope you're not going to contradict me.
Absolutely agree, totally, because we do know that estrogen is protective. So estrogen, you know, makes this nice protective layer in the blood vessels, so you don't have this buildup of plaque. So obviously, if you've got your ovaries removed, certainly at a young age, you're at increased risk now of heart attacks or ischemic heart disease. And we know that estrogen is beneficial in terms of protecting you against osteoporosis, and your brain needs estrogen too. So in terms of, you know, what is the percentage, I can't actually answer that question right now, because everybody, as you said, Terri, it's individual, and every consultation in terms of, you know, what you need to do is individual when you see your HRT specialist.
Okay, thank you. So I have a question here that I might direct to Reem, actually. So it says, I have just recovered from triple negative breast cancer at 37. I have had a double mastectomy. As I am BRCA2, does this increase my recurrence rate?
Well, you already developed breast cancer, so your recurrence comes from the risk of a breast cancer. You got bilateral mastectomy, so your risk has gone down from your genetic point of view. We never say there is no more breast cells left, so you can develop another cancer, which is quite rare because your breast tissue left behind less than 2%. But your prognosis and outcome will come from your first cancer you diagnosed with. Don't you agree, Terri?
Yeah, absolutely. So the risk of recurrence is very difficult to estimate because it depends on the stage of the first cancer, and it also depends on the type of treatment that you've had afterwards. So if you've had chemotherapy, if you've had tamoxifen, if you've had radiotherapy, all of those factors will reduce the risk of recurrence. But unfortunately, your risk of recurrence, what I would say is actually the studies have shown that the recurrence risk in people with BRCA mutations is the same as the recurrence risk of a woman with the same stage and grade of breast cancer diagnosis at the same age that doesn't have a BRCA mutation. Yeah, exactly. But Reem said very nicely, the risk reduction is in terms of your second breast cancer risk. The risk of recurrence will have been managed by your treatment.
Great. Okay, I hope that answers that question nicely. So we've got one here, I think, to yourself, Terri. Is there anything we should be doing in line with pancreatic cancer? Assume you can't screen and just need an awareness of symptoms.
Yeah, this is really, really tricky. So this screening for pancreatic cancer is not proven yet. There's a really big study happening called EuroPac, which is being run through Liverpool, but involving lots of different centres in the UK. And what they're looking at is the utility of screening in people that are at very high risk of pancreatic cancer. So they will include families with BRCA2 if there's more than 2 affected family members. They're not including people with BRCA1 alterations at present because the risk isn't thought to be as high as BRCA2. But the screening that they're looking at is really involved and quite invasive. So it involves a CT scan every year. It involves an endoscopic ultrasound. So they put a camera down the gullet and look at the pancreas from the inside out. A blood test every year, pancreatic juice sampling, which is as disgusting as it sounds. And it's very invasive. So a lot of my patients that have been enrolled to that study have actually either withdrawn or have phoned me up to give out to me for inflicting it on them, So I know there's different places that are certainly looking at potentially, rolling out screening for pancreatic cancer, but really they're only considering it for the very, very high risk families. And actually the level of risk associated with BRCA alterations, yes, it's increased, but it depends on the way you describe high risk, because yes, the risk is twice the background population risk, but that still is only 5%. So your risk of never developing pancreatic cancer is 95% or more. So really to put yourself through that kind of screening that isn't proven is not going to be beneficial yet. So at the minute, we certainly, we're keeping a very, very close eye on the screening, absolutely, because pancreatic cancer is so serious that if we can find a screening test for it, absolutely, we'll be rolling it out immediately. But you have to make sure a screening test is safe, useful, and effective before you roll it out, so we're keeping an eye on it. At present, the best thing you can do is stop smoking or never start, because smoking definitely increases the risk of pancreatic cancer. The other things, it sounds very boring, but maintaining a healthy weight, maintaining a moderate alcohol intake, because all of those factors, obesity, alcohol, smoking, are the big kind of lifestyle factors for pancreatic cancer. So the best thing you can do to modify your risk of that is make sure that you keep healthy otherwise.
Thank you very much. So we'll take one more question. We're a little bit over time, but I think this is the burning question. I think that everybody in the audience wants to know. And we have about 90 people in the audience now, so that's fantastic. Is it likely that there will be an ability to switch off the fault in the gene in the future? And if so, when do you think this might be trialed? That'll probably be to you, Terri.
That's the dream. The dream is that we'd be able to go in and kind of use our molecular scissors and correct the gene fault. I don't think it's beyond the realms of possibility, but I think we're quite a way away from it at the minute. So obviously they've looked at some of this technology in embryos. So before birth, obviously they've looked at correcting gene changes in embryos. There have been reports of some mutation, and obviously there was that horrible case in China where the guy was doing all kinds of weird experiments on embryos that he shouldn't have been. I think it's very premature to start doing it in embryos yet because the technology just isn't safe enough, because the difficulty is, like I said earlier, your genomic information is like a big instruction manual. But if you think about any instruction manual, how often will you see the word "the"? So THE, you'll see that word repeated all over the place. So if you're correcting a spelling mistake in BRCA, you're looking for every time "the" appears, because that's where the alteration is. You'll end up correcting changes in all the "ths" in the genome. And that's the same issue that happens with gene editing. So they've had what they call off-target effects. So you try to correct one spelling mistake, but what happens is you correct that apparent mistake in other parts of the genome. So you could end up, okay, correcting your BRCA mutation, but then causing lots of other mutations elsewhere. So the technology is certainly being worked on. And I think definitely in a couple of years' time, well, we don't know. It's crystal ball kind of territory, knowing when that technology will be ready for use in embryos or in people. And of course, then there's a huge body of ethical considerations there as well. So I think it's a more of a complex question than can be addressed in this time. Not now, basically, is to cut a long story short. I think not right now.
Yeah. It is the dream, as you say, Terri. I suppose, like, I've just had to go ahead to ask a couple of more questions. There's so many questions here, but I think we'll have to take them offline. But it's really encouraging. Thank you, audience, for putting through so many questions, because we now know, as our first webinar has been very interactive. And before we go to the last question, I want to thank everybody in the panel here. I think we've learned and grown together over the last few weeks. It has been challenging, but we got there. And I'd like to thank you before we leave. But I suppose one final question we'll take here. Hello, this is Tina. Hello, I'm 57, BRCA1, and had TNBC cancer, and also had preventative oophorectomy surgery, which showed sections from the fallopian tubes showing P53 staining, and thankfully caught on time. My question is, are BRCA1 still at risk of other types of cancers after the surgery, example, uterine cancer, and would a full hysterectomy be recommended? Thank you. Terri, I'd say for you.
Okay, so that P53 signature that Tina mentions there, that's really interesting actually. So P53 signature is basically when a normal cell sort of shows early signs that it could be turning sinister. So that's the best time you want to catch a cancer, is when the cell is still normal and kind of thinking about maybe turning cancerous. So Tina was very lucky actually in her timing there. In terms of the cancer risk after that kind of operation, the one that we tell people to be mindful of is primary peritoneal cancer. So your peritoneum is an organ that lines the inside of the abdomen, basically. It's like an inside type of skin, if you like, which is a very kind of weird way of putting it, but it basically lines all the organs in the abdomen. The cells that make up the peritoneum are very closely linked to the cells of the ovary. You can't remove your peritoneum without causing huge morbidity. So there's about a 4% residual risk of developing cancer of the peritoneum. In terms of the risk of cancer of the womb, as far as we know, the risk of cancer of the womb is not increased in BRCA carriers compared to the general population, but as a woman, you still have a risk of cancer of the womb. So your risk isn't zero, but we don't think it's increased compared to the general population, and we don't recommend doing a hysterectomy routinely for that.
Okay, thank you very much. So could I ask each of the panelists maybe just to think about one thing they'd want to say to the audience, given that there's almost 90 people out there. What would you like, Terri, what would you like to tell our audience after today's sessions?
I would tell them to look at my lovely website, and if they want to see more videos of me, to go on. No, in all seriousness, that the website is cancergenetics.ie. And actually what Abby said earlier on about there not being an Irish website at the time of her own diagnosis is part of the reason I developed that website. It's very much contextualized to the Irish situation. Killian very kindly did a video for me as well. So if you miss us after this webinar, you can go on and look at our videos up there as well. But it does have some useful information about the pancreatic cancer. It has links out to the different studies that we've mentioned today. So the impact study, the protector study, all of that. So hopefully people will find it useful.
Thank you, Terri. Killian,
I have, sorry. Yeah, I have one closing sentences I want all people to remember. There is no one procedure, one pathway that will fit all. So we have to remember what might suit your sister regard any way of ovary at certain age, breast surgery, that it might not work for you. So it's important to be remembering it's individuals that we have to look at. Yes, they all have a BRCA, but it might be differently treated by all for each one of them.
Thank you,
Thank
Reem.
you.
Claire, what would you like to say?
I suppose I'd just like to highlight that your genetic counselling team, like we are there. So I guess sometimes people do quite well initially after a result, but if it's 6 months, a year, 2 years down the line, do pick up the phone. We will do follow-up appointments for you or even phone consultations. So don't feel like you can't go back to your genetics team. Please use us. That's what we're there for.
Thanks, Claire. Killian?
Yes, thanks, Helen. I'd just like to say that whether you're BRCA positive or BRCA negative, if you're worried about prostate cancer, go and talk to your GP or urologist and get a PSA blood test.
Great. Deirdre?
I would like to say that women should not be afraid of HRT. We can tweak their treatments, and basically you literally have to outweigh the benefits and the risks and consider that, yes, we are outliving our ovaries at this stage, whether we have them or not, and we have still another 30 or 40 years left to live. So please consider your quality of life also.
Thank you, Deirdre. And Eoin?
Ellen, I'd just like to say that I think what you, Abby, and the peer-to-peer team have been doing is brilliant. I think you're kind of filling a gap
Here. Yeah.
that probably shouldn't need to be filled. But I've been directing all my patients towards the group, and if there's anything we can do to support the group, we'd be more than happy to do that.
And thank you, Eoin, you already have, and you have too, Claire. And Abby, finally, as one who's walked in the shoes of BRCA, what can you say?
Of which there are really very, very many of us, and I'm just one representative, really. Yeah, everybody has a different path. I think two things to say. One is to definitely log on to the Mary Keating website and have a look. It's the only, apart from cancergenetics.ie, it's the only website that has information that can support you. And it's so great to see that people who have this mutation, who haven't had cancer, finally have a home, somewhere to land, because often you're pushed into the cancer services bracket, and that can be very frustrating, and it's just wonderful to have that support. So again, I just like to reiterate my thanks to all the panel here and to everybody at Mary Keating for the support. And if you're an attendee, make sure you check out the website and reach out if you feel you need support.
Thanks so much. Well, for me, I'm going to introduce you to Liz Yates, our CEO now, but I certainly feel like we've become a BRCA family over the last few weeks. Thank you so much for your time and your patience and lots of going. It has been a great pleasure. And I'm delighted that it's nearly over because there's been not too many hiccups, but we will be back. So now I'd like to hand you over to Liz, our CEO. Thank you all.
Thanks, Helen.
Thank you, Helen.
Good afternoon, everybody. Thank you so much to all of you. I think we've had a fantastic session this morning. It's been such a powerful overview, the fantastic variety of knowledge and insights from such a wide range of expert speakers on all aspects of BRCA. Sorry, I think, Helen, you might just have to unmute me there. Sorry.
Unmute me. Oh, so, oh yeah. Sorry now.
You're ready, you can go, Liz.
Okay, so I'm not sure if everybody heard me just there, but again, I just wanted to say what an amazing morning it has been. I think we've all learned a huge amount about different aspects of BRCA. So those of you who have attended previous conferences held over the last couple of years, and also new members who have joined our BRCA community today, it was fantastic to see so many of you dialing in. I suppose the Marie Keating Foundation is particularly proud to have been able to bring today's seminar to you, particularly against the backdrop of COVID, when obviously we were challenged whether or not we would be in a position to proceed with it. But we're just so delighted that we've been able to bring this to you. And I think actually, because it's been recorded and we'll be able to share the whole presentation with you, we'll also be able to send it out to wider audiences. So possibly it's a blessing in disguise in some ways, because it will get a better reach and more people will benefit from the insights of our experts this morning. So I just want to thank a number of people. Well, first of all of our speakers and panelists, I think, to give up not only this morning for sharing your expertise and knowledge, but we've had a couple of dress rehearsals and dry runs, and just really, really appreciate all you've been able to, all the sharing you've given us. Thank you so much. Also to our sponsors, so both MSD and AstraZeneca have been our sponsors for the last 3 years in terms of enabling us to bring this seminar to you. As you know, the Marie Keating Foundation is a small charity. We don't get any government funding, so we're particularly reliant on organisations and donations from the public in order to deliver our services. And right now, during COVID-19, I suppose people affected by cancer are all the more in need of our services, because a lot of cancer patients are cocooning, they're in the vulnerable groups, and they need our support more than ever. So it's really important that we're in a position to adapt nimbly and to provide our patient support and advisory services to our cancer and BRCA communities through online means. So thanks again, both to MSD and AstraZeneca for sticking with us. We had put a lot of planning into this event, and we were adamant that we weren't going to let it go by the wayside, as we've had to do with a lot of fundraising events, for example, with the physical distancing guidance. So really delighted that we were able to keep going with this event today. I also want to thank Helen in particular, who has been your MC this morning, and as our Director of Nursing has been absolutely integral in terms of organising and planning this conference. Thank you, Helen, who has also been very much involved with all the BRCA group over the last 3 years, and is such a key part of our team. So thank you to Helen. To Jen, our Senior Communications Manager, who has been behind the scenes largely, but playing a huge role in terms of enabling the technology and the invitation and the registration process. Thank you so much, Jen, and for advertising the event and the website information as well. And to Bernie, thank you for your support, Bernie, with today and managing all the questions. And to the wider Marie Keating team, thank you so much. To Zoom and to Axel. Axel has been on hand throughout our dry runs and today and guiding us through this webinar. So I hope you have been able to receive it well and to hear and see the presentations very clearly. But thank you so much for your support, Axel. We really, really appreciate it. And last but not least, to all of you in the audience, thank you for staying with us. I see most of you are still have stayed with us for the long haul, so thank you for that. I know it's been a long morning, but we will be sending out to you the video, as I said, and we'll also compile a kind of question and answer session. So I know a lot of the questions were answered within the panelist session there, but there's quite a few questions that weren't answered. So we will curate those and get them up on our website for you to see and share the link with you after the seminar. So just to say thank you again. I think we've come a long way in the last 3 years in the BRCA community. When we started out first, it was very tentative. As Abby and Reem have said, really there was very little there to support anybody who was tested positive with the BRCA alteration. And we've a lot more to do, but we've come some way. And I think having such a diverse range of panelists and building up that multidisciplinary range of supports over the years will, I suppose, ensure that we have the best in class services for the BRCA community, because they absolutely deserve that. And we will play our part at the Marie Keating Foundation in continuing to agitate with the Department of Health, the National Cancer Control Programme, to ensure that the National Cancer Strategy recommendations in relation to cancer and hereditary cancers are actually implemented. So we will play our part in that regard and continue to support the peer-to-peer group and in their advocacy efforts as well. And a huge thank you to our peer-to-peer volunteers, not just for today. Abby, thank you so much for outlining so clearly what you do in that group, but for your support all year round. I know your advice and your guidance to any other people who raise their queries to you has been hugely valuable, and we're so proud to support you on that as well. So without further ado, thank you again for dialing into us. We will send out the links to you with the video and with the question and answers, and do stay in touch. Keep an eye on the Marie Keating website. We will be putting up further information as it evolves on our website. So thank you again.